Good morning and welcome to the second day of this meeting. I hope all of you enjoyed the dinner last night and slept well. We'll get started. Today's focus will be mainly on type B aortic dissection. And the first panel will be discussing impact of aortic arch anatomy on procedure choice. I think something that we did allude to yesterday, and the role of bicuspid valve in when we choose therapy for type B aortic dissection. So for discussion, Dr. George Joseph, Rajshekar is not here. Vijay has also left. Shivananda, he'll be coming in. He's just finishing breakfast. Dr. Rajesh Vijayvargiya, Dr. Venkatesh. Dr. Digvijay, would you like to join instead of Vijay Thakur? And Dr. Ram Subramaniam was supposed to be here, but he hasn't come as it. So you have the, can we have the projection? Like yesterday, we try and follow this, but if there is something else that you would like to discuss, entirely up to the panel.
The first task is, how does variation in aortic arch anatomy, angulation, diameters, and branching patterns influence the choice between TIVAR and open surgery? जॉर्ज सर से शुरू करेंगे इसमें तो.
Yeah, so since we are talking specifically about type B dissection, we know that type B dissection, the treatment of choice is TIVAR if possible, and surgery is if TIVAR is not feasible or anatomically not feasible. So what is the anatomy that makes TIVAR difficult for type B dissection? Most type B dissections start straight after the left subclavian artery. So the landing zone, in my experience, is invariably zone 2 if you want to get a good seal. Very rare that you get a zone 3 good landing zone, which means that the entry tear should be a good at least 2 centimeters beyond the left subclavian. So that's very unusual. So we are looking at a zone 2 with some sort of procedure to preserve flow into the left subclavian artery. So that could be a carotid subclavian bypass, fenestration. Some people use chimneys, but I think that's going out of vogue. So if you're looking at an endovascular option, so you need a good zone 2 length. So the distance between the left carotid to the left subclavian should be at least 1.5 centimeters to get a good thing. And the other thing is what they call Gothic arch. So if there is a very sharp angulation of the aorta in the region of the left subclavian or just beyond it, then endograft is unlikely to, take that bend and give you a good seal. So you may have either an instability or you may have a bird beaking. So that's the second anatomical problem that TIVAR would face. And the third would be an anomalous right subclavian artery, which is taking off beyond the left subclavian artery. So then you would knock off both the subclavians if you did a zone 2, which would mean some kind of hybrid procedure. So these are some, and the fourth is probably a single vertebral artery arising directly from the arch, which is again commonly between the left carotid and the left subclavian. So if the right vertebral is small or absent, then you would want to preserve this left vertebral artery. So again, endovascular is quite tough to do a fenestration for the left vertebral artery, which is directly taking off from the arch. So in these situations, I would think that surgery, open surgery should be considered. We could discuss these and then.
What's your experience on that?
Yeah, we've done right aortic arch. That doesn't change anything. It's just that the carotids now have separate. Sometimes you have separate origins of the two carotids. So you will have left carotid, right carotid, and then the two subclavians taking off. So you have 4 origins. But we are still working distally, so it's carotids don't come into the equation if you are doing zone 2 or 3 repair. So if these anatomical features, then there are more. I just talked about the arch, but if your axis is bad, very tortuous iliacs or aortic tortuosity, sometimes you have this very severe tortuosity of the lower descending aorta, and that's often very difficult to get your endograft through. So that is another situation where the TVAR may actually fail because you can't deliver the graft. So offhand, I can think of these as anatomic situations where TVAR may be challenging or not possible.
So what would you consider a safe landing? 1.5 or 2 centimeters for the arch?
I would say 2 is best, and it's not like any 2, a straight 2.
Yeah.
So if you have a 2 with a sharp bend, I don't think that's
So
going to
the
work.
measurements also differ on the outer curvature versus the inner curvature.
Right.
So where do you take the measurement?
Usually we measure the outer curvature. It's difficult to get 2 on the inner curvature, because if you get 2 on the inner, then your outer may be like 4 or something. So we generally look at the outer curvature and take it at that. The other issue now then is the diameter. So the aortic arch is a tapering structure. At the innominate, it's usually quite big. And by the time you cross the subclavian, in some patients, it's almost half the size. So you can have a dramatic reduction in diameter as you go around the arch. And so you need to size according to your proximal landing zone. So your proximal landing zone, if you actually measure it, may seem quite big when you compare it with the descending aorta. And in dissection, you don't want to oversize. So measuring that proximal landing zone precisely and then doing a 0 to 5% oversizing is a very important thing in type B dissection. If you oversize considerably, that is one of the risk factors for a retrograde type A dissection. So I waste a lot of time, or maybe it's not a waste, but I spend a lot of time deciding what should my proximal landing zone diameter be. I mean, what should my endograft be in the proximal landing zone? So that is very important consideration. So,
how do you assess the size at the?
yeah, so the true lumen often is just like a slit, So there I measure the length of the length of that slit, and imagine that that is the diameter. So if that is 21 or 22, then I go for my smallest distal end of endograft, which for a tapered Cook device is 24 currently. So they have this Cook dissection graft. It's a TX2, but they call it ZDEG, Zenith Dissection Endograft. And that has an 8 mm taper. So the smallest they have is 32-24. So we will deploy a 32-24 first, ending just above the celiac. then go in with a cylindrical arch graft. And there I'm only worrying about the proximal diameter. So the distal diameter is not a worry because even if it's oversized, it's getting into the lower graft. So I don't have a design problem there. So design I've taken care of by ending as small as possible. And retrograde type A I'm minimizing by starting as low as possible. But there is a risk. What if you are undersized? Let's say you started in zone 0 with an undersized endograft, then you will see contrast getting in under the graft, and that can be dangerous because it's like a cul-de-sac. It's a closed space, and with each cardiac contraction, blood is being pushed into that, and in diastole it comes back. So that keeps enlarging, and we actually had an aortic rupture like that. The way we figured out its rupture is the patient just suddenly died, and the only two possibilities, a cardiac tamponade and a rupture. And we did an echo, a post-mortem echo on the bedside, and there was no blood in the pericardium. And in one case, we actually got a chest X-ray done on the bedside, and there was hemothorax. So we knew it was a rupture. So ending in the zone 0 with an undersized graft is also not a safe thing. So both oversizing and undersizing have problems. So sizing is a extremely important thing, especially proximally.
Yeah, what is your take on yesterday? Somebody made a statement of covering up to the left carotid routinely.
You mean a zone 2 repair?
Yeah.
Zone 2 repair is, I favor that because it gives us better, that is usually the transverse arch, between the left carotid and the left subclavian. It's generally a kind of straight segment. At the subclavian and that zone 3 is where usually that bend is. So I don't like ending in that zone 3. It's a tricky place to start an endograft. And you'll have this free flow, kind of bird beaking upwards and digging into the wall. And zone 2 is always better. So I would think that today, if you get a type B dissection, electively plan to bypass the left subclavian or do a left subclavian fenestration and preserve the left subclavian at all costs and start in zone 2 just beyond the left carotid. That will give you a much better.
Yesterday, Saurav was telling about covering the left carotid also.
Oh, if you're covering the left carotid.
No, as a routine.
Okay. So the point against that is, if you have noticed, the zone 1 is almost non-existent in most patients. The innominate and the left carotid are almost touching each other, or in many cases, they take off together. So covering the left carotid is not going to give you any great advantage. You may get few millimeters. Pardon? Yeah, you get the diameter of the carotid, but then you are kind of encroaching on it. During a deployment, if you went wrong and you accidentally covered the left carotid, then you are in trouble. You'll have to do something urgently. Just last week, I happened to be in Indonesia, and they had this live case of the same thing. The operator wanted to start in zone 2 and accidentally covered the left carotid. And they were not prepared for that eventuality. And this was in a place where they couldn't very quickly mobilize surgeon, and he was not familiar with carotid puncture. So they lost about half an hour and patient had a stroke. I don't think, if you're thinking of coming close to the carotid, you should have a backup mechanism. So the way I do that is, I routinely stick the left carotid with a micropuncture needle, and I put a 4 French sheath in, and I keep the pressure connected to that. Now the advantage is, if you have covered the carotid and the pressure has dropped, you know that you need to do something about it. You can very rapidly convert this to a chimney if you want. What do you do when the procedure is over? You just pull it out and just press. You don't need any kind of closure device, nothing. So 4 French direct carotid puncture is an extremely safe procedure if done under ultrasound, and if you avoid the internal jugular vein. You shouldn't go through the jugular vein into the carotid because you'll end up with a fistula. So that is sometimes tricky. So you need to turn the head, go up or down under ultrasound, choose a spot where you directly enter the left carotid. But having a left carotid access is very important when you are deploying your graft very close to the left carotid origin. And if you're thinking of zone 1 or zone 0, it's best to have pacing so that you drop the pressure. This risk of the whole thing getting pushed back is not there. So I think you should, I find vascular surgeons are a bit reluctant to pace because of unfamiliarity. So in that situation, in Europe, they actually do a different thing. They drop the pressure by either a chemical means. They sometimes give adenosine, or they inflate a balloon in the inferior vena cava and reduce the venous return to the heart, and that also is effective. Otherwise, call your cardiology colleague and just pace. But don't try arch endograft deployment with the whole, the LV contracting, and this where you end up can be disastrous, if you're not able to control it. So best is to pace or drop the BP somehow or the other.
So what factors might sort of make you decide to do a complete aortic replacement rather than just deal with the distal arch? So which means replacing the ascending aorta. So what are those factors? Because there are times when it might be either a dilated arch, though dissection is not extending there. So what is the threshold for that?
Yeah, so there again, it's anatomy. So there are many patients where you'll notice the 3 arch vessels take off very close to each other with hardly any space in between them. And also there is a sharp curvature in that region. So there again, zone 1 and zone 2 are again extremely small and in the curved segment. So that is a situation where I would like to go into the zone 0 and have fenestrations for all 3, or you need to bypass all 3. So that is one situation. The other is if the ascending and arch are already quite big, then if you start in zone 2 or 3, there is a high risk of retrograde type A. So there I deliberately go well into the zone 0. And doesn't mean that I can't dissect there. I can, but I find 2 things. One is that the dissection of zone 0, when I've gone near the ST junction, is usually a very focal dissection. It doesn't usually cause problems. Second, our surgeons are quite happy to deal with that dissection. If it happens, they just open, do a root replacement, anastomose their graft to our graft. And it's quite a simple procedure.
And if the ascending is very large, when we are covering this, Dr. Javli does Y graft and also constrains the ascending aorta, externally. And that, helps us put a smaller endograft.
So that is a procedure that we were doing earlier, constraining the ascending aorta. So we reduce the size of the stent graft coming into the ascending aorta. What do you think might be the implications of that procedure on root dilatation in future?
If the patient doesn't have any other aortopathies like, familial or bicuspid aortic valve, in that case?
Yeah. I mean, so would that, it becomes like in some way a bit of a quack.
Yeah, so external wrapping of the ascending aorta is a well-described technique of creating a landing zone for a zone 0 endovascular repair. So we have actually got our surgeons to do that for us a few times and done very well. So for them, the surgery is quite easy, just a thoracotomy and 1 wrap, and they are out. So they don't need bypass or anything. And then we go in a few weeks later once the thoracotomy is healed, and then we have a very nice landing zone. So if you are doing a total debranching, so there are 2 things. One is the takeoff should be as low as possible so that you have more of a landing zone, and that landing zone should be healthy. So you can create security there by doing a wrap over there.
But would that banding sort of have any impact on controlling the blood pressure, dilatation of the LV or dilatation of the root in the long run?
So the banding should not leave a gradient. So the degree to which the band is also very important. So I would think that you need between 25 to 30 ascending aortic diameter to have a unrestricted LV outflow. Because most surgical grafts are in that range.
So you
So
have a 9 tube graft cut longitudinally and you get a 30 diameter there.
Should not be that of a problem because we are only bending up to the normal sized aorta and there's going to be a stent in it very soon. So वो होना नहीं चाहिए उसमें. That bending has to be secure. I agree. Because we are not going to like squeeze it. It's going to have a loop and इतना करना है तो I would go for open, sir, by the way.
I'm not sure whether that is the right thing, because the fact that the aorta is dilated and you want to restrict the size so that you can put an endograft indicates that the other part of the aorta is also diseased, right? So there is definitely going to be at some point either the distal or proximal part of the aorta, whether it's a root or arch, is going to dilate if it is not already dilated. It's not as if there is an isolated small segment which you feel that it's dilated and then you put that external restraint. I don't think that's the right way to think. What about the root? Root.
wrap.
No, Dr. Shekhar, it is not a wrap. It is a constriction, and if you have an ascending aortic diameter of, let's say, 40 millimeters, and we put a wrap to bring it down to maybe 34 or 32 or even 30, the part from where the branch takes off below the wrap is still 40. And that is diseased segment.
Correct.
So that is the only reason I have my doubts that is it going to remain stable in future, or is there a potential for that to dilate and also result in root dilatation and LV issues?
I think if you have a dilated root and proximal ascending, then don't do wrap. Do replace the whole ascending and the root and take off your graft from that.
That would be the right option, because it's not like a small saccular aneurysm coming off. You're talking about a diffuse dilatation of the aorta and you want to put the entire arch covered with endograft. So you might as well treat the root.
Absolutely.
So-
proper operation.
So, Dr. Gopichan, in terms of the concern remains whether you would want to go on pump and replace the ascending aorta, or would you be just happy remaining off pump and put a wrap and put a site widening clamp and do the anastomosis? So does it really add a lot to the morbidity if you're going on pump and replacing the ascending aorta?
Putting a patient on a heart-lung machine doesn't really bother me because we're already a cardiac surgeons, so there's a huge familiarity. The other thing is, you remember we did a young guy with a type B dissection. We used a small minimally invasive surgery, right anterior thoracotomy, to put a 12 graft onto the lowest part of the descending aorta ascending aorta where the aorta is normal. And then we used a Y graft and made a small cut here, connected to the innominate and left carotid, that Y graft, without opening the chest, without putting the patient on bypass. And then you can have the TVAR coming up to cover the descending aorta where there's no landing zone for type B, where you want to come into zone 0. You can do a minimally invasive and use a Y graft to connect both the carotids. And then you create a very long, stable landing zone. We've done that already. So that's easy to do. Where there is a diffuse dilatation of the ascending aorta, wrapping is not going to work. It has to be a formal planned root replacement, and then subsequently you can do an endo procedure for the distal part of the arch or even the branches.
So in your solution that you just mentioned, so the endograft is going to land in a zone 0 dilated aorta. Is that correct?
This was actually, what we did was a type B dissection where there is no landing zone at all.
Yeah.
Once that you're talking about subclavian,
Yeah.
very close to subclavian entry point. So either you have to cover the entire thing,
Yeah.
or you go and do a arch replacement. What we did, it's a young guy. So we used a Y graft using a 12 and 8 diaphragm. We did that on table, on the bench. And then we used a minimally invasive to attach it to very proximal.
But that was a normal sized descending
Normal,
aorta.
that's
That
normal.
was a normal sized descending aorta. So if a patient has a bicuspid valve, would your threshold change in terms of attempting or wanting to replace the ascending aorta?
No, the differentiator for a surgeon is two: A, longevity of the patient, and B, are the sinuses dilated or not dilated? If the sinuses are dilated, there is no shortcut possible because they are going to dilate, they are going to create a problem. So we do either valve sparing. If the valve is involved, then Bental. And the question is, if the arch is normal, do we give debranching or not? Arch is not normal, or if there's any doubt of aortopathy, it might be today's day and age safer to do a debranching. While we're doing debranching, make sure that the ascending aortic anastomosis is as low as possible to facilitate your procedure in the future. It should be that kind of a very straightforward thinking. If the patient is debilitated, old, with a limited longevity, then the whole ball game is different, and we have to use our philosophy.
Too much of a gray zone for us, but the thumb rule that we follow is anything around 4 centimeter. If I'm doing, say, some kind of surgical intervention, whether it is wrap or any kind of aortoplasty, does not make any difference. If this aorta has to become big, it will become big. The thumb rule is, if I'm going down, then I would definitely consider replacing it. The wrapping or anything really doesn't change the progress of the disease.
It may not change the progress of the disease, but you will get a more secure endovascular repair, which is maybe in the short term, that is good. But what happens in the root, we cannot say. Now, one thing is, it is not just endovascular repair that causes retrograde type A dissection. Even surgical ascending bypass anastomosis can set off, that side biting clamp. All these can cause ascending aortic dissection. So this is the worry. When a whole ascending and root is diseased, like in a genetic aortopathy, already dilated, any of these manipulations have this risk. So the best solution is replace the ascending, do a Bental, and then extend distally. But you have to look at elderly patient, comorbidities, high-risk situations, then you may have to.
In a situation where you have done zone 0 deployment, and if this patient comes back for, say, a surgical replacement of root or wall, how exactly do they manage the zone 0 in terms of clamping? And
Excellent. So this is the question the surgeons always ask me. Okay, I have got my endograft coming down almost to ST junction. What do we do? I say clamp the graft. So these are self-expanding compressible grafts. Clamp right across it as close to the innominate as you want. And then do your repair, anastomosis it, and then release the clamp. Nothing happens to the graft.
Yeah, I agree with you. I have done 4 retrodissection till now. I feel A, retrodissection while you're doing the arch are more common than you imagine. B, the clamping with the soft pads in the blades is not a problem. And thirdly, doing anastomosis over the flanges is also not a problem at all. There's quite a lot of good strength. And all these 4 cases, we had to clamp on the graft, on the flange.
So one more controversy. Now, if we are,
so no clamping, what was the bare metal versus non-bare metal proximal? Does it make a difference?
Yeah. So let me elaborate on that. So the surgeon goes in and clamps the graft near to the innominate, opens the aorta, and then you remove that free flow. See that the first segment is bare. So it is sutured onto the graft at 5 points. All you have to do is take a blade and nick off those 5 sutures. The whole free flow segment comes off as one piece. So you don't have to cut metal or anything like that. It's very easy to remove that piece. Then you have got the surgical, endograft. So they do I'm not a surgeon, but I'll tell you what they do. They have this felt inside, outside, surgical graft, endograft. So you got 4 layers sutured all around. Beautiful anastomosis, so it works very nice.
So we were talking about type B dissection and landing your graft in zone 0 with the debranching. Now, the problem that it creates for future is that if you need to re-intervene lower down in future and you plan for endo repair, you're basically stuck because you don't have branches aligned for you to go down from above into, let's say, the SMA or the cilia. Would a frozen elephant trunk be a good option?
Absolutely. That is, I groan when I say total arch debranching and it taking off from ascending, and then I have to do a thoraco-abdominal because then it's a nightmare because all I've got is 2 femoral accesses and I have to get all my fenestrations cannulated from below. So it can be very, very challenging. Whereas if you have an access from above, it makes the whole game different. So if it's a FET, beautiful, because you got access from any of the arch vessels, you can go right down the descending, and always better for the interventionist to have a FET done earlier rather than a total debranching.
Sir, I think it's a trade-off. We are talking about a type B dissection. To talk about FET in this kind of cases, you have to think whether you put a 40 graft in zone 0 has its problem, or just do debranch and just cover the arch. That kind of a thing. For type B, when we go and talk to the patient about frozen elephant trunk, it's going to be a difficult conversation, I think. So we, as Dr. Javli said, looking at the other patient comorbidities and age and longevity, I think we have to make a rational decision at that time.
The patients that we see quite often in our practice are not the 60s or 70s or 80s. We typically see patients in 30s and 40s who come with type B aortic dissection. And if they don't have any other major pathology, I think they should have a long way to go, barring, of course, the aortic complications and if we are not able to tackle them in future. So what Dr. George Joseph described, one of the earlier cases that we did, we had done a debranching and then we wanted to do a T-bar. And then we were not able to get in the true lumen from below. And I had to go from the brachial into the ascending aorta from that branch, get the wire turned around, snare that from below, and then get access from below into the true lumen. It's obviously very tough to do it once the anatomy is altered. So one way would be to do a 3-vessel fenestration. But again, for young patients who are likely to have aortopathies or genetic disorders, it may not be the best option in the long run. So that is the reason we brought a FET.
I think what worries always these future reinterventions that are needed in type Bs, because we are still having this patent false lumen hanging lower down. We are not completely addressing as much as we can. So when we were doing these cases, we always have this doubt. Is there a role right at the beginning when you think that this patient is at a high risk for progression of the disease lower down and becoming a complex thoracoabdominal problem? Can we address the false lumen right at the beginning when you have dealt with the type B dissection? Like, whatever different techniques we use to occlude the distal lumen so that you are not making it 0, but at least decreasing the chance of the complex thoracoabdominal disease, which may need future reinterventions.
Yeah, so that is a very valid point. We tend to think that once you have done a TVAR, story is over. Actually, it is just half the job done. The abdominal segment is still dissected. That needs surveillance for many years. And then what do you do when that starts growing? So we have now very commonly doing these completion endovascular repairs. That is, we have done a TVAR before, now we're doing the entire abdominal segment right up to the iliacs with 4 fenestrations. So those are completion repairs. So that is now quite a standard procedure, and the numbers are going up because now we have this floating population of TVAR patients who had a TVAR and now are following up, and now we're picking up this growth of the abdominal segment. So that is where an access from above is crucial. So if we are able to come from above and cannulate the fenestrations, it makes a huge difference, makes it much more easy. Whereas if the arch has been debranched and now I have to do a abdominal segment completion repair, it can be a nightmare. You may actually not succeed. So,
Any thresholds you have generally as a group, like for example, 4.5 centimeters combined lumen above the celiac. Do you want to address in the first sitting itself?
yeah, so first sitting, generally we don't like to do the entire thoracic abdominal segment in one shot. And because there are risks of paraplegia and such like, makes the whole procedure complex, takes more time. So there are these solutions you mentioned. What about a candy plug or the other options? I feel that that is not the way to go. If you're going to do something, wait a month or two and then do a completion repair. And that's the best way, because then the whole dissection has been treated. Rather than, just fix the thoracic part and then not have anything done for the abdominal part. Because finally the abdominal part will give trouble if it is growing. So I think better is to do a completion repair with a fenestrated 4-fen completion repair.
I have a small query, sir. Standard type B dissection, but in this patient, what I saw was aberrant right subclavian artery with the left arch. What are the options at that time?
Yeah, great. So aberrant left subclavian artery, 4 fenestrations for the arch. So we regularly do that. So there are a number of situations where we do 4 arch fenestrations. One is an aberrant right subclavian artery. The other is a giant innominate artery. So there is no stent that can oppose in that, and a giant or a short innominate artery. So I have then 2 fenestrations for the innominate and 2 stents, one going into the right carotid, one going into the right subclavian, and then 2 more for the left carotid, left subclavian. So a 4-fen repair for a giant innominate, sometimes for a bovine trunk or a very short innominate, or for a anomalous right subclavian artery. Once we did it for a single left vertebral artery direct from the arch. So these are situations where we may need 4 arch fenestrations. Otherwise, you need surgical debranching.
So for the total repair, do you prefer to go where there is a need to have a fenestration for the abdominal vessels in the patient with the type B dissection? Any preference for say TVAR followed by EVAR or EVAR followed by TVAR, something like that? Or do you wait for time being to have the regression of the false liver? As there is a concern about say arterial access. In case it's a fenestration, you have to come from above you fenestrate the mesenteric and the renal arteries. Is there any concern about the arterial access? What I said, zone 0, zone 1, TVAR in type B dissection?
Yeah, we just talked about that. To do an abdominal segment fenestrated repair or branch repair, it is very, very useful to have access from above. And access from above, if you're doing an arch repair, it should be either a fenestrated arch repair or a FET kind of repair, where it is easy to come down from above to the descending aorta. That is what I would prefer as an interventionist. But the situation when the arch repair was being done has to be taken into account. The surgeon may not be happy doing an FET. He may just want to debranch, and that's the situation then. So, but we have the problem down the line.
So do you always revascularize the left subclavian in case it's been covered with the graft stent for this type of the cases? carotid subclavian bypass followed by zone 2 TIVAR.
Yeah, if you did a zone 2 TIVAR, you still have the nominate to come down from. So that is no problem. That's fine. You can use the right axillary or the right carotid and come down. So that is no problem. But if the total arch is debranched and you've got a single big graft taking off from the proximal ascending, then it's impossible to come from arm or carotid and then go down the descending aorta. You'll have a very tortuous thing. You can't manipulate. It's impossible.
So when you have these fenestrations in the aortic arch and the branches going into carotid and subclavian, if we are going to intervene in the future, how comfortable is it to use these fenestrations with the grafts jutting into the main graft? Do they remain stable during our interventions, or is there a risk of sort of dislodging them or causing an endoleak?
To add further, do an adequate guide support to the penetration for intervention of mesenteric arteries and renal circle?
Great question. So this is exactly what we've done. So we use the fluency self-expanding covered stent for the arch fenestrations. So the beauty of these stents is that they are, even if you, distort them by a catheter or an endograft going past, they just fall back into place. So, and you can go through them. So typically we use this percutaneous axillary approach. So we have 3 7F sheaths going in here, going through the innominate stent. So 3 of them going through the innominate stent, going down the endograft and reaching the abdominal aorta. So we have 3 accesses like that. And we finish the completion repair. And then we put a single covered fluency stent where we punctured in the proximal first part of the right axillary arch. So not a problem at all.
And my final question, have you tried the stabilized technique to obliterate the false tube? A lot of it, I mean, there's a lot of publications, a lot is spoken about it in conferences.
I haven't used it. So we initially used to do candy plugs, but now we're going away from that and doing completion repairs rather than doing candy plugs. So I don't mind some retrograde filling of the false lumen from below after a TVAR. What I'm looking at is what's happening to the abdominal segment or the lower thoracic segment. If that is growing, then you need to do a completion repair all the way to the iliacs.
Sorry, just one last comment. Personal experience. If somebody is lucky, they have a single entry point and a supposedly single distal exit point. I'm saying any personal experiences, because we have done one and our experience was not that great, like sealing only the top end and the bottom end, top end with TVAR and bottom end with some kind of covered stents to just seal the distal hole. Any experience with that?
No, what happened? Like, what was negative about that?
I think the progression happened subsequently. Even though on CT, it was very clear that there is only one entry and one exit.
So was there false lumen filling after the procedure?
Not at the end of our procedure.
But that may have been there later for it to
Yeah,
grow.
I think patient presented with acute abdominal pain, back pain, and succumbed in ER. So
actually, what may have happened is this. You may have actually had 3 entry tears, one in the thoracic, one in the iliac, and one somewhere in the abdominal. Now, suppose you close the top one and the bottom one and just leave the middle one. Then you convert that false lumen into a cul-de-sac with no exit. And then that false lumen will grow and rupture. So that is a dangerous situation. So it has happened to us. So you think you've covered everything, but the worst thing is to leave a single entry tear into a false lumen without an exit. That leads to growth and rupture. So
I think we were kind of guided by the CT appearance, but as you know, the gross specimen anatomy shows, it's never 1 or 2 holes anyway. There are like
with many
multiple sieves. So CT is probably not the foolproof way to determine.
But at the same time, I think there is no jury is out on this that you have to deal with the re-entry tear down below. Surveillance is the way you finish your initial procedure.
I think we were like trying to get the good outcome or final outcome so that we don't want to re-intervene.
We had one patient.
The proximal, the larger entry itself should be enough. All you need to do is wait, keep a watch on the distal one, whether it is dilating further or not, to decide whether any other procedure is required. It need not be done in the same sitting.
Yes, regarding this point, we had one patient type B dissection with multiple entry, one more in the abdominal aorta. So after putting a 200 millimeter stent covering the left subclavian, patient just in the CCU got collapsed. He had autopsy done. And then there was a dissection distal to the stented segment, and that led to perforation. As Dr. John Joseph rightly mentioned about it. They came into pressure effect of the false lumen and the cul-de-sac phenomena, and it may rupture the aorta, which is unstented in the abdominal part. We have a proven autopsy which has shown the perforation just distal to the stented segment.
So this brings us to a rule. It's not written anywhere, but it's a rule that we have learned the hard way. When you are repairing a dissection, start at the entry tear and work your way down. Never do like a patchy job, a little bit on top, a little bit at the bottom with nothing in between, because that can create a lot of trouble. So if you are coming down sequentially, link your second repair to your first repair. You keep moving down, then you're safer. I don't say you no problem at all, but it is dangerous to do skip zones. You do one bit on top, one bit on the bottom, and leave the middle untreated. That is dangerous. You may get that issue of just having a cul-de-sac which will rupture or things like that. Rupture is the greatest risk in that situation.
Now we proceed with the task. We go to the bicuspid valve. You have a TABD and a bicuspid valve. How would the presence of a bicuspid aortic valve after risk stratification change your treatment regarding the type B dissection?
So type B dissection is something like a genetic aortopathy. Type B aortic valve. It's not linked to any particular specific gene. There are multiple genes that have been found in type B. None of them describe more than 5 to 10% of bicuspid aortic valve. So it's not like Louis Dietz or Marfan's, where you have one or two genes. Here, there are multiple genes. So there is a genetic component, but we haven't identified it. But practically, when we're dealing with these patients, you've got to deal with it like this is a genetic aortopathy. And you have to give all the respect a genetic aortopathy deserves when you are working on a type B dissection with a bicuspid aortic valve. So everything follows that way.
I think the biggest thing in dealing just with the type B aortic dissection in a bicuspid aortic valve is more intense surveillance. I think that's in the absence of any initial large ascending aorta or valvular disease. Even then, I think a very intense surveillance. In that case, what imaging modality would you prefer?
CT is always the best imaging modality in dissections, but many of these are young patients, and you are looking at a lifelong surveillance that is required. So I start getting worried when you have a very intensive, very frequent CT imaging protocol. So we are now increasingly moving to MRI for these patients, or if you're looking at the ascending, just an echo may be enough. Coming back to this type B, if I were to do a zone 0 repair for a type B dissection, I will nowadays first have a chat with my thoracic surgeon and say that, okay, I have this guy with a bicuspid aortic valve. I'm doing a zone 0 or zone 2, usually it's zone 0 aortic repair. And I know that this ascending aorta is going to give trouble in the future. You will have to bail us out when that either expands or dissects. And they are increasingly happy doing that. So it's like we have, the traditional teaching is when you're repairing the aorta, start proximally and go distally. So doing only a descending aortic repair and not treating the ascending is against the philosophy or teaching. But I think that has to change because it is possible to reverse that order. You can do the arch descending and then have a surgical ascending repair done. And the two can be linked. That's the important message I would like to convey. Because it looks like, suppose somebody comes with a type B dissection, young patient, and you say, okay, you've got a bicuspid aortic valve. We are going to do an entire ascending arch, descending repair. It's a huge procedure. It's just, and the dissection is not ending even at the diaphragm, it's going all the way down to the iliacs. So it may be prudent. Just do a zone 0 to celiac repair endovascular and then watch. And as and when the ascending gives trouble, get that replaced.
I think what we at least have observed in our practice in the real world is the moment the counseling starts opening the chest, the can of worms associated with that, I think patients just back off. I think that is the real world experience for us. So if it is for them, okay, we are just doing something in the neck, carotid subclavian bypass, and we are doing a TVAR. I think the acceptance levels are slightly better the moment we say, this discussion. I think there's a very valid learning point personally for us, for me anyway, that yes, surgically this can be dealt with in those complex situations if you have the cardiac surgeons on board right at the beginning.
Yeah, so the essence then is to have an endograft in zone 0 because then the surgeon can clamp it and then do a anastomosis. If your endograft is in zone 2, then the surgeon has a bigger job to do. He has to do ascending plus arch plus find this graft in zone 2 or 3 and anastomosis. That's quite difficult. It's much easier for the surgeon if you start at zone 0. So that he has a ready-made anastomotic site, so, and he doesn't have to touch the arch branches. They're all taken care of. So it's a simple surgery for them.
But for type B dissection and aortic bicuspid aorta, do you still prefer to go for zone 0 TVAR?
Yeah,
or zone
absolutely. So I treat bicuspid valve as genetic aortopathy. So I start zone 0. And
despite having a aorta, ascending aorta dimension
normal.
less than 40.
Yeah, absolutely. So genetic aortopathies, we generally always start zone 0. Because these are the ones who will have these bad retrograde A dissections if you are doing zone 2 or zone 3. And those retrograde A's are usually fatal. And you can't save them. That's
Well, I'm not sure about. Is there any data to go ahead with zone 2 TVAR versus zone 0 TVAR for aortic valve disease, bicuspid aortic valve
no,
and type B dissection?
I don't
To
think
go
there
so
is.
aggressive and then having the fenestration for all the 3 vessels instead of say having a zone 2 TVAR in bicuspid.
Okay, so I will put you the counter. So what is the conventional teaching? Like patient has bicuspid aortic valve and has come with a type B dissection. And let's say the ascending aorta is already slightly dilated. Conventional teaching is you do a surgical FET. So isn't that aggressive? I mean, that is much more aggressive than doing a zone 0 TVAR, wait and watch, and as and when the ascending gives trouble, do the surgery.
We'll conclude.
We covered all the points.
Yeah.
That's good.
Thank you so much. I think that was good discussion. So we'll have just about maybe just under an hour for the next panel because we have an online talk on genetic risk stratification starting at 10:10. So next panel, Dr. Rochan. Dr. Rajesh can stay there. And Ajay Sablania. And others are missing. So, Dr. Tanu Saha, would you like to join this panel? So this is going to be on acute aortic syndromes other than the standard type A and type B dissection.
So let's say start the second session about intramural hematoma and penetrating ulcer. So conservative versus intervention management. So how to decide about in a patient who is symptomatic versus asymptomatic.
I think for IMH, we have to think of IMH just like we think of dissection. There is, if you have a type A location, for the IMH, I don't think there's any sense in doing any conservative stuff. You need to go in and replace that aorta because if and when it converts, you may not get a second chance to do it. So if you already got a warning, you need to intervene. For type B, the situation where the locations are relatively, if I may say, benign, it becomes similar to dealing with an uncomplicated type B dissection or so. If you have persistent symptoms, yes, you should intervene. If the IMH alters rapidly, yes, you should intervene. If the IMH is stable, non-symptomatic, maybe you can wait and watch that. I think that would be my approach.
You mean to say type A is the one where the aggressive management is the type B is the one where one can go conservatively for the time being to look for the radiological surveillance, how much it's increasing of the time, and then to decide.
Yes. If you have an extensive IMH, of course, I think then, I mean, there is no clear-cut thing to say what is too big an IMH, but if you have an extensive IMH in the sense that it's extending for a considerable length along the aorta, I think I would treat it like I would treat a dissection in any case.
There are some high risk factors has been described with regard to IMH. One strategy, like sir has told, that we treat it like AD actually for ascending aorta, obviously the surgical therapy, and for B, if it uncomplicated medical therapy. But there are some high risk factors, like if the size is more than 45 to 50, I'm talking about descending aorta, and then the thickness of the hematoma more than 12 mm, 13 mm, and if it is expanding over the time, patient is having continuous pain, peri-aortic hematoma, pleural effusion, all these are the high risk factor which suggests that we should intervene.
That will make it complicated. Any of these features would mean it's complicated.
Yes, sir.
Yes, please.
I'm Dr. Fujikawa. Actually, for type A IMH, in Hong Kong, we have a little bit different strategy. So if we got type A IMH patient, and if the IMH thickness is less than 10 mm, we observe. And if patient doesn't have any pericardial effusion, we still observe. So of course, we let them admit, and we keep them in high DU and keep BP monitoring and closely monitor the patient's status. And if BP control is poor, and if we know that some increasing of pericardial effusion, at that time we proceed hemias. But even if it's IMH, if IMH thickness is much bigger than 10 mm, we just proceed as you mentioned. This is the point.
This is probably for IMH type A. And how long you wait, actually would like to wait, that if patient is stable, it is not expanding?
Actually, underlying, if we measure the ascending aortic diameter less than 45 mm, we can observe. And actually, some of patients can be recover. So just IMH is a few months later, it's completely diminished some cases. Actually, this is not my previous opinion, because when I was in Japan, that center was crazy, so no turn down policy, and even 80 years old, and anytime doing operation type A dissection. So even IMH, no need to care, just type A, just do it. But when I came to Hong Kong, my mind was a bit changed, and in Hong Kong, actually, type A dissection surgery quality is not so bad. overall mortality is about 5 to 7% mortality in type A dissection, emergent type A dissection surgery. But still, we are observing this kind of IMH. And of course, some patients need to be converted to the open surgery later. So if patients show some increasing of pericardial effusion or some persistent pain, we need to take CT scan immediately, and we go to the theater. Or a few months later, if patient ascending dilated, we just proceed as an elective operation. This is a Hong Kong standard.
So I have like this policy is for all group of patient or for very high risk where life expectancy is.
Even younger patient, we still observe.
So your study do get change with say associated aortopathy, aortic dimension more than 40 or 45 in case it's been associated with a IMH or penetrating ulcer.
Yes. So if the size is less than 40 and the patient didn't have any pericardial effusion and very thin IMH, we no matter how any genetic issue or some age, we still observe fast.
So you are classifying them into low risk IMH and high risk IMH. High risk IMH needs to be operated. Low risk you can watch.
Yes.
It's a bit of a conundrum as to how long will you watch them, I would say.
And actually, normally this patient who is admitted for 2 weeks.
Okay.
The Western data with regard to this policy is totally different. They always go for a upfront surgery for type A IMH, but the Asian, particularly Japanese data, they are adopting this policy, but they maintain a very low threshold for surgery in these patients also, of course, with the early.
So this management is almost similar with uncomplicated type B.
I think your benchmark for saying the aorta is dilated, 40, 45, 50. Where are you on that?
It's generally for the emergent operation for type A IMH 45.
I think the recent guideline clearly supports the view what Fujikawa was telling, that in a non-high risk type A IMH, it's worth observing. It's a class 2 A or B indication. I don't know. Provided the dimension is 45 or less, with no other risk factor, and the thickness of the IMH is 5 millimeter, not greater than 10 millimeters. And this is one area where we can watch it. And how long? I think the studies have shown that the maximum incidence of acute events is in the first 1 week. I'm not sure about 2 weeks. 7 days you critically observe. And if they stabilize over the period of time, probably you can extend your observation. Otherwise, go in. I think this is a very selected. I think it's a deviation from our constant thinking that type A IMH, go bang, bang, repair it like, IMH repair like type A. But this is the 2024 guideline gives this 2B or 2A indication. I'm not sure about it. Exactly.
So Rachan, one question for you on the radiology part. When we say 40 mm, like Dr. Fujikawa says, where do we measure 40? Is it the inner diameter? Is it the outer wall to wall diameter that say this is 40?
So we normally, when we talk about measuring the ascending aorta, there are two problems. One is, do you have a ECG gated CT scan? Because if you don't, then your variation is enough to, take away any idea that this is an accurate measurement. Echo is a little bit different. You can probably measure that on echo much better. I would normally talk about aortic dimensions when we talk about it. It's generally outer wall to outer wall dimension that we talk about. The location of the measurement, I think at any point at the STJ and above, if you've got any measurement which is more than that. Plus, there's the added criteria of the ascending aortic length also. In some centers, they follow that too. But to do a prophylactic surgery in an asymptomatic individual can become challenging with just this.
This is not asymptomatic. I'm talking about IMH.
Yeah.
Where would you measure it?
Even in IMH, the patient can be asymptomatic.
So okay, you have a symptomatic patient, you've done a CT.
Yeah.
You find that the thickness of the IMH is less than 10 mm.
Okay.
And based on Dr. Fujikawa's suggestion, we have decided conservative therapy.
Yeah.
So where do you measure that 40, 45, 30,
Any-
outer
I
wall
think-
to wall?
Outer wall to outer wall. And if there's anywhere dimension bigger than that, that is a soft indication for operating in any case. You have to debate that as to whether with or without the IMH, you would still consider whether this patient needs to undergo surgery.
Now the IMH can vary. I mean, most of the IMH may be, let's say 5 mm, but there are a couple of spots where it's a little thicker, 10 mm. So what would you decide based on the maximum that is available, or like the most of it maximum?
It's the maximum which matters.
Sir, one question.
But I really would like to know one thing. It's a very difficult question for me to understand. If you have IMH dimensions, how many patients have you had a follow-up on to see what happens? This is the problem, when we look at these decisions and these guidelines, the data which supports this in the background, that is always a little, to my mind, it's very debatable as to you have enough data to say.
Yeah, exactly.
But we are guided in the point of should we intervene now or should we wait? That is the only question which comes up. I guess sooner or later they will need something.
In fact, so the extension of your question is in your own experience, all those patients who were managed conservatively, how many of them actually needed acute intervention, and what was the morbidity in morbidity or mortality in those conservative IMH patients converted into acute surgery in comparison to, electively operated IMH? Dr. Fujiwara.
You have a follow-up on these patients that you have treated conservatively?
The same with uncomplicated type B. So after we let them discharge 3 months time and 6 months time and 1 year time. And our Hong Kong group has already published about the result of long-term follow-up of this kind of group. So we divided two groups, conservative treatment and some patients, of course, later converted to the open surgery, but most of them are electively, and that mortality is very low.
But
20 to 30%.
If I may add, actually, we as clinicians, we know that we have already lost patients. We do lose patients with IMH waiting in the ward, or waiting in the CCU, getting operated, relatively asymptomatic patients. Now, my question is there any rationale that we should be waiting for the disaster to happen in an uncomplicated IMH? How long can we wait in the CCU in our setup? 10, 15 days waiting for a disaster to happen, or waiting for the patients to get better? What is the rationale? IMH type A, should we wait or should we not?
I think
and to add further, Dr. Roshan can comment about how to have the surveillance of this patient, how frequently 0, 7 days, 30 days, 3 months, 12 months, and what are the various parameters which has to be looked into, other than say size of IMH less than 5 or more than 10 millimeter. Is there any need to look for, say, aortic wall thickness? How to assess about the aortic dissection or perforation?
See, any variation in the IMH is relevant in the sense that if your IMH is increasing in thickness or extending in location, or the aortic diameter is increasing, any of this would say that this is not stable. So that is pretty okay. Now, how often to surveil them? We tend to follow the 0361 plan for most things. However, there's very little, what shall I say, data to say that you should do it more frequently or less frequently than this. We don't really know what the perfect answer is, but most of us will follow the 0361, 3 months, 6 months, 1 year, and then annually plan for most of these patients, because it's impractical to image too much because you will be using radiation, or say even calling the patient in for an MRI is troublesome. I don't think we really know a perfect answer to that question. In the surveillance, some patients may suddenly become acute, and if they're lucky, they'll end up in hospital in time. I really have no way to say why we do this the way we do it.
And sorry, another reason we observe this kind of type A IMH, actually this type A IMH, we are dividing two groups, thick IMH and thin IMH. And furthermore, in IMH is less chance to have a sudden disaster. This is one of the reasons. Another reason is social background in Hong Kong. So as for the working environment, sometimes if we perform this kind of operation during nighttime, our ICU easy to refuse next day's elective operation. So is that the case? If we can observe and we can wait for the operation, we can still keep our elective operation. So this is some social strategy as well. So this is probably each center can have each answer.
Dr. Fujikawa, there was a question from Dr. Atano that how you, because the mortality is so high in a IMH type A, how you rationalize that we will go for a medical therapy in this patient?
Actually, it's mortality in type A IMH is mortality is not so high. So the conversion ratio of open surgery is 20 to 30%. But those operations is what's done electively, and elective operation mortality is almost 0%. Just for hemiarch replacement.
The question was, what is the rationale behind waiting for an IMH uncomplicated admitted? Point is, few of those patients will definitely have a type A dissection in their due course of time. So when they dissect, obviously the mortality increases. Even the operative mortality will increase. So why do we wait? The tissue becomes better if the blood in the IMH becomes like.
You mean in type A change to type A IMH change to normal type A dissection?
Yes.
So, sorry, I cannot catch the meaning.
No, I think the clarity is here that you said 30% of them convert at some point in time to so the 70% never need surgery.
Yes.
Correct. So that's why you want a surgery, major surgery on them. That is the whole logic of waiting, because surgery per se carries a mortality. The benefit risk ratio of any surgical procedure has to be weighed against the natural history of the disease. So when type A IMH is less than, that is the reason the guidelines share type A to A indication for observation when the IMH is less than. But we are all scared to do that. That's a different story. But that's a science which tells us now. So 70% you avoid a surgery which has whatever it is as an emergency. It varies between 10 to 40% in an acute, when you do it in acute as a surgical procedure. So if that is 30%, 70%, by observing, you avoid them any surgery. And with the understanding that this IMH resolves and remodels and becomes a normal aorta.
Sometimes the patient can ascending aorta is recovered to completely normal. So I cannot identify whether a patient had truly had previous type A IMH or not.
So, Dr. Fujikawa, the 30% of patients who had to be operated later, what was the indication in these patients for surgery?
Some indication is dilation of ascending aorta, or change the, as you mentioned, change to just type A dissection. So new onset second dissection. So, but if that's the case, we need to proceed emergent operation. But otherwise, if it's dilated or dilated ascending aorta or much getting thicker of IMH more than 10 mm, if that's the case, we just proceed as a semi-elective operation and much safer.
So there's also one question I would like to ask. If you had a patient with IMH, he may or may not normalize. Is that patient now a high-risk patient who should be monitored subsequently through his lifetime? If a patient had an IMH, never operated, resolved, now do we consider him a high-risk patient who needs monitoring for his lifetime in the future?
Actually, we observe regularly CT scan, and of course, we need to explain to the patient and the risk of operation. But at least at the time, IMH is not so thick and ascending is not dilated. Actually, this is no indication of operation.
So different question. What I meant was, you had a patient, you observed him, he was low risk, he was fine. The IMH subsequently resolved. What is the future counseling for this patient? He is now, in a way, a patient who is not normal population.
The surveillance.
High risk person. What is the surveillance program for this patient?
And to add,
Yeah. Plus, do we monitor them with echo? Do we do CT scan annually on these patients? What do we want to do?
Yeah.
and
You
and
just
to
need
add,
for a
and to
PP now.
add further about the etiology of IMH, whether it's a hypertension, atherosclerosis, or aortopathy. What's going to be the strategy for the surveillance for the lifelong?
Just BP monitoring and the medication and regular CT scan. It's just enough. Our management is much more.
Once in a year CT scan. Sir.
And we should also go by the thing, when we do a type A dissection, we have seen some patients where the false lumen completely obliterates distally. 6, 8 years down the lane, you hardly can see any disease in the descending aorta. Such a long dissection heals off. So there are patients who heals off, to give them an opportunity.
We are talking about the thickness. Does the vertical extent also matters right at the initial presentation, rather than just the thickness in type B? Is there any, I know there is no studies rationale or evidence as of now, but are there any personal experiences? Okay, this may proceed, this may not proceed.
I don't think, I at least don't have enough personal experience to talk about anything at all. We don't see that many numbers of type B IMH, which is, long enough. But I would say we would look at it this way. If your IMH is big enough that it's looking like a dissection, put it that way, then probably you should treat it like a dissection. Give that.
So more than 20 millimeters is the one, and then of course there are various other parameters which has to be look into to decide about whether to go aggressive or the conservative management. There are various radiological finding which is very much suggestive how the IMH is progressing about.
If you have progression or complexity of the IMH, then I don't think there's any question that it is deep. I mean, in all ways, you should treat it like a dissection.
And
if it is progressing or got complicated, or there's any, the only issue here becomes, what do you treat as a complicated IMH? Is some fat stranding on the aorta enough? Is, symptomatic IMH which doesn't resolve in 2 days pain-wise enough? Where do you draw the line is the question, which is not very clear, especially with type B. Type A, you are much more clear about what to do in some ways. Type B, it's really hard to say what to do. Like this is the case with type B dissection. Essentially, we believe that it's the same spectrum is from IMH to dissection. So essentially, the data problem that we have with type B, we have the same problem with IMH.
The imaging features are there, sir.
So-
Focal intimal disruption and imaging malperfusion in IMH also makes
Yeah, I
indication.
think that the next topic is about the aortic ulcer as well. It's penetrating aortic ulcer. So you have a scenario where a craggy aorta with IMH and maybe a small penetrating ulcer may not be at the same place, but at a different place. So, it just gets complicated. So
Yes.
can we just treat it anyway, like a dissection?
See, I would give an opinion, but that is an opinion. We don't have data to support what we say. And that's always a problem when we have a discussion. I mean, in a given patient, I feel this patient is not doing so well. Aorta looks very bad. Do I really want to keep calling him back, surveilling him, keep him in the hospital long term? Or should I just treat it and, send him home? It's not as if treating him is so simple either. I mean, if you're covering a long segment of the aorta, the question of spinal cord ischemia comes up. All the complications of TVAR that we talk about keep coming into the discussion. We don't really know what the natural history is actually. Unless you have population-based surveys, you not know. It's not such a common thing to see.
So just, adding to it, complicated patient, IMH with a bicuspid valve.
See, let me put a question to you on the one. You're talking of type A IMH, we'll go ahead and do surgery. But suppose the IMH, you are seeing it in the arch as well as descending down. Where are you going to stop? What is the point in just replacing only the ascending?
I really cannot say there is a perfect answer to this question. It will have to be something which progresses, like we talk about type B. Say you see it's a small type B dissection, which is in the descending beyond the left subclavian. Are you going to treat it, not treat it? The question needs to be answered by enough data. We don't have that data, so I can give an opinion. What does it mean? It's just my opinion. That's it.
So most of the data with regard to IMH type A is derived from extrapolated from Stanford A dissection.
No, I know. What I'm saying is there is an entry point in the ascending aorta. So you have to fix that. There is no one single problem, single point of trouble here. The entire aorta is showing the problem. So there is no rationale in saying I will replace the ascending. What if the other penetrating ulcer in the descending aorta ruptures?
Just coming to the type B IMH, sir. Like since we don't have an entry tear, how do we decide how much are we covering with the TVAR if we need to proceed with treating a type B IMH? Like when we do in a type B AD, our focus is to treat the entry point and the proximal thoracic. So in type B, where do we land? Do we treat all the way down till the wherever the IMH is?
There is no, even in dissection, you don't just treat the entry tear. Right now, I think all of us believe that you have to treat as much as you can safely treat. That means between the left subclavian and the celiac, you cover as much as you can, because the simple fact is you cannot see all the entry points or exit points in the intimal tears. You cannot see all of them. We know that CT grossly underestimates the degree of this thing that exists. Unless we know exactly, I would put it this way. Is the entire aorta normal? I don't think if you have a dissection anywhere in the aorta is normal. Unless that's an iatrogenic dissection. That aorta is abnormal. That patient will get more dissections. The patient is likely to progress, which is the rationale for, say, improved AD trial and things like that. To say that if you have even an uncomplicated dissection, you should treat that patient because the patient is going to progress and become more difficult to treat in the future, is going to have complications in the future, is the rationale for treatment. Similarly, in IMH, unless the IMH is small and resolves and goes away quietly, in which case you have deferred the problem, hopefully, you have to treat it as if it is, dissection. So you would cover an amount of aorta that would depend on the location of the IMH. You have to cover the IMH area for sure. And you have to cover so much that you don't significantly increase the risk of spinal cord ischemia, which would depend on other factors as well. What is the sex of the patient? Whether there are other comorbidities? Which area are you covering? Is there significant spinal cord supply being affected by your covering? I think the principles remain the same as type B treatment.
So there is a favorable anatomy where you land up proximally in healthy area and distally in healthy area. Then if you have another form of anatomy where you have a proximal healthy area like Stanford B dissection, but distally you land up in the IMH. But you should try to cover as much as FIIDs or TIDs, the ULPs and all has been described. And then you have a third scenario where there is no landing proximally distally, which is like mostly managed with the surgical therapy.
But the fact that there is a hematoma formation itself indicates that entry point is limited. There are no multiple entry points or exits. If there is an exit or multiple entries, most likely it continues as a dissection. Hematoma formation will be much, much lesser. So in that context, I mean, I do believe probably, closing that entry point would definitely help these patients, unlike a frank type B dissection.
I would say that the same principles apply. Without, in an IMH, you don't want to do too much also. It's probably not justified to do too much. But is there any way of knowing how much is too much? I don't have a simple answer for this. I would use a short stent graft as much as I can, but cover the entire area of the IMH.
I have a question about the proximal end. So we often have type B dissection with a retrograde extension of intramural hematoma, which goes into the arch. And similarly, you have just IMH, which starts in the ascending, and you may have that U-lip or whatever you call that further down. So the treatment of either of these two conditions should start from normal. Normal means ahead of the IMH. So you cannot start saying, okay, this is where the entry tear is. I will just start above that. If you have IMH going more proximal to that, that also needs to be covered. So proximal, I think, is vital. Distally, you may not be able to do it because of risk of spinal cord ischemia. There, you may have to stage it. If it's giving trouble, then later on do some further work.
So how the things do get regress over the time when it's a type B dissection with intramural hematoma extending into the aortic arch, and yet you just cover the left subclavian only instead of say having a zone 0, zone 1 reconstruction.
Well, you may get away with it in some cases, but there is always the risk that your endograft will cut through the flap and create a new entry tear. Because
I think what he said is absolutely clear. When you do a stent graft, normal to normal is your ideal. Whether that normal to normal compromises too much of the spinal cord perfusion is the question you have to deal with when you do it. It's like any other aortic therapy. There has to be a balance between what is the perfect result, which may leave the patient with a problem, versus accepting suboptimal result in a with saying that this is too risky to do. That's the way it works out. In type B dissection, if you see, the section is extending all the way to the iliacs. But do we treat the entire abdominal visceral segment and below in every? We don't. We do the upper part, which is, causing the problem right now, and wait and see what happens. So maybe a similar strategy is what we're talking about here. Do what can be safely done without a problem. If needed, if you feel that you still have to treat, maybe stage the therapy, give the patient time to adapt the perfusion to the spinal cord, etc., and then do the second step if you want to. But again, going too much into trying to treat everything that you see may be pointless, as is shown by the fact that many type B patients actually never need the procedure.
Shall we move ahead with the penetrating aortic ulcer, when to intervene?
Yeah, so PAUs, I guess if you have anything which is bigger than 15 mm, and there are two criteria given, 10 millimeter neck of the ulcer, but 15 mm depth of the ulcer, all that. Symptomatic ulcer, again, it's similar to what we talk about in type B. When we call it uncomplicated, don't treat. So an uncomplicated PAU, if I may call it that, you observe and watch and see what happens. And I guess similar principles apply to monitoring, how to monitor, when to monitor, similar. But I think the location of the PAU does matter. If you have a PAU in an area which is very difficult to treat by any means other than surgical, then I guess you will have to consider that should I treat this patient upfront optimally? Because once it is nearer to the root, your options of endovascular is limited. So maybe you need to look at that also.
So what will be your policy if penetrating atherosclerotic ulcer is there in the ascending aorta?
So penetrating atherosclerotic ulcer in the ascending aorta, yes, definitely we'll like to operate because they are much more prone to rupture. And ascending aorta being an unsupported structure, unlike the descending and the arch, they tend to rupture. So I'll definitely go and operate.
So penetrating ulcer or IMH type A, should we wait to have an aortic dissection and have an total aortic reconstruction, or to have a focal stenting with a TVAR? That's the question.
The ascending aorta, I think, unless the patient is unfit for surgery, I would opt for surgery, because doing a TVAR in that zone, in case there's a future need for something, may be a problem for the surgeon. So let's look at risk assessment on an individualized basis, sort of low risk patient. Definitely, the lower the surgical risk, the more I would tend towards surgery, unless the patient is absolutely unable to undergo surgery for various reasons, like previous, bypass surgery, compromising your ability to operate, things like that. I would say surgery would be my first option in almost all cases in the ascending.
Sir, with regard to imaging, they have told that more than 13 or 15 millimeter diameter of the PAU that makes a high risk for its rupture actually. So what is the exact measurement? Where do we measure when they say like this actually?
Whenever you measure a PAU or any kind of aneurysm, it is outer to outer, always that diameter which matters. They also talk about the neck of the PAU, treating it like an aneurysm. If that is more than 10 millimeter, it is assumed that this is a significant entry tear, if I may call it that, because obviously in a PAU, the intima is disrupted. So you're looking at it that way.
No, sir. That is fine. The neck is like more than 10. I'm talking about the diameter of PAU because
Yeah.
if we'll take outer to outer, it may be the including the aortic, the remnant 2/3 part of the aorta, which is normal. That also we are taking.
Not the diameter of the aorta, diameter of the PAU.
That's
itself.
what. That's what, sir. Where will be the measurement
So
transfer?
it is actually the depth of excavation, if you were to call it that we're talking about when it's 15 millimeters.
Dr. Rochan, I think there is that one picture there. Can you see that?
It's not here, it's
Yeah.
there.
Can you just, I think for non-radiology sometimes the depth perception is like,
Yeah.
the horizontal.
Yeah, so you got to get cross section of the point which you're looking at. Don't look at it in other projections. That means you have to have your, I mean, this is getting a little technical, that your reconstruction of that image in CT should be directly looking at going cross-sectional at the point of the PAU, which means it's not necessarily a sagittal or coronal body plane. It is a plane which is aligned to the aorta. So, and that plane you measure the depth of how much the PAU has penetrated, because that tells you how likely this PAU is to rupture. And the idea is that if it is more, if it's 15 or more, then this is a more likely to rupture because the aortic wall is that much more, wall is more compromised at that point. It's weak.
So I think unlike in IMH, Dr. Pant, I think you have been a bit more categorical in your number 15 here.
I am what the literature says.
So
I personally cannot say that I've seen so many that I can tell you
So
something.
can just ask, the experts here who have been dealing with them, is it, acceptable? We all agree at least 15 even if it's a low risk patient, 15 mm depth is a good guide for us to, in a safe location, especially in a descending, which is easier to treat. Is it okay for us to go ahead and treat them?
I'd like to add one point. See, just look at that CT on the screen there. Can you see the aorta? This is the arch. The whole aorta has plaque or atherosthrombus. So PAU in the arch, if you were to attempt to treat it endovascularly, you have a risk of stroke.
Yeah.
And then so that is one issue. Second is, I have a patient with a PAU between the superior mesenteric and the two renals. Now, if I have to treat that, I have to do a 4-fenestrated repair, a lot of work. So that's another situation where I've backed out. And I believe that these patients need high dose statin therapy. And I use evolocumab, which is a PCSK9 inhibitor, and get the LDL to like 20 or 30. And keep it that way. And then you will see that this regresses. So I have two patients like that. So very aggressive lipid lowering therapy is a way to go when you have a PAU in a very dangerous place.
Yeah.
Like
Risk of treatment versus likelihood of problem with the PAU is a very difficult question to answer because we don't have enough natural life history of PAU available to us. It's particularly in India because the problem we face here is that our aortas actually are very different, both size-wise and behavior-wise. Maybe the pathologies are different in India. We see much younger patients. We see a lot of associated thrombus, atherosclerosis, whatever you want to call it, with PAUs, etc. So it's hard to say. If I cannot treat it easily, I may try medical therapy for sure. Yes, why not? Monitor. So aggressive monitoring is also a challenge in our country. A lot of patients don't want to do that. I agree with it.
I think it's a very valid point, sir, about the aggressive medical therapy, because we were all talking about the surgical interventions, but I think it's a good point to raise so that we all have at least back of our mind that, okay, there is another alternative rather than just treating them surgically.
So, with regard to these kind of situation, the shared decision goes without saying actually, because patient also decides for their treatment, these kind of.
Patient always has a say.
Yeah, so we have quickly, we have 10 minutes and we can discuss.
Non-A, non-B dissection is the next part that we're going to talk about, and I would like to hear from people if they have any opinion that this should be treated differently from either A or B. That's the question to be answered here. We are saying this group of patients where your resection involves the arch, not the ascending aorta, may or may not also involve the descending aorta. The entry tear as classified can be arising in the descending or arising in the arch itself. And these two seem to be a little different in their behavior. But what is the opinion of George? What do you think?
Yeah, zone 0 repair, there's no question about it.
I think so. No conserving in non and non-B.
No, I don't. If you have a non-A, non-B, then doing a zone 3 TIVAR is dangerous. So you have to cover the arch. And if you're covering the arch, you go to zone 0. There's no point doing zone 1.
Exactly. Once you are in the arch, you probably don't, in most of these cases, there is no safe landing zone before zone 0. Yeah, that's fair. Now, when we have a non-A, non-B, and are you going to think about conserving or not? It is not aneurysmal. The patient does not have any features of complication. Are you going to conserve him or not conserve? That'll be the first question, I think. Are you going to treat it like an uncomplicated type B, which technically it is? In the sense that if you go by the classic Stanford, something not involved in the ascending is type B. If it's not complicated, are you going to conserve or you're never going to conserve? That's the question.
Yeah, so here I will bring in patient factors, like what are the comorbidities, and if it's low risk for intervention situation, I will still go ahead and treat it. Only the high risk for intervention, I would probably do a conservative.
Surgical opinions, Dr. Fujikawa, what do you think?
It depends on just size of aortic arch. So even if this kind of non-A, non-B dissection, if arch is not dilated, I just observe, treat conservatively.
Like for type, you treat it like a type B in other words, that there is no indication for intervention, I will not do.
Yes.
Any other thoughts? The only thing is the natural history of non-A, non-B, especially with an arch entry tear, is very different from a standard type B in the sense that it tends to get complicated more than a standard type B. So any thoughts that?
Even if you look at, we are looking at the old Stanford A and B. And the very reason the classifications have been refined further with the TEM classification, because the point of entry makes a difference. And when the entry point is in the arch, it comes under, I think, 1 or 2.
E2.
E2. Yeah. So obviously there is a difference in the prognosis of these patients compared to when the entry is further distal. And I think that may be one reason why we might consider treating these patients differently compared to standard type B.
So is there a consensus that, I mean, there's an opinion from Dr. Fujikawa that we should treat it like type B and just watch and see what happens. That whereas there are opinions that if it is low risk to treat, we should go ahead and treat by whatever means. I mean, if you're happy with surgery, do surgery. If you're happy with endovascular, do that.
So like the data, the conclusion they have remarked is if the size is normal and it is non-A, that it will goes with the medical management. If the size of the aorta is more and patient is symptomatic or imaging features suggest that there is a supraaortic vessels are encroaching upon, then a case for the treatment.
No, the reason for pushing a little more aggressively in these patients is that once the dissection extends on conservative therapy, chances are that it will involve the supraaortic branches. Type B is a different thing. I mean, unless it's a proximal progression and it becomes type A then it's a different ballgame. But here there is a risk of involvement of the branches.
And in an emergent situation, you may have to operate in that situation, definitely, which is very challenging.
So we may not have an answer to this today, But I think these are the things that I would keep in mind when deciding whether to manage conservatively or to go in for.
Maybe we should have a
intervention.
show of hands to say who says we should intervene as early as possible and who says no.
Intervene.
Okay.
I think I have one question to Dr. George Joseph. Would you always go for zone 0, or if it's a type 1 type of aortic arch where you have a horizontal thing and you have a landing zone at zone 1, you would still go with that?
Yeah, so if you have a very good zone 2, there are some patients like that where there's a good 2 centimeters between the left carotid and the left subclavian. There, I've done zone 2 repair.
Yeah, that's not very common for us to see that much of a gap between left carotid and left subclavian.
Yeah.
Generally speaking, if it would also mean where is the aorta curved and where is it, parallel and straight for us to deploy enough of a seal zone. That seal zone problem is that though companies talk about 2 centimeter, 1 centimeter, 1.5, I think if for me, as far as possible,
more the better.
I would like to have 2.5 to 3 centimeters of seal zone, which usually in most patients is only available in zone 0. It's not available before that.
There's one point about this non-A, non-B. I feel that this is a early version of a retrograde type A dissection, and there is a risk of it progressing into the ascending aorta. That's why I think it is more sinister than a regular type B dissection.
Natural history suggests that these patients tend to land up more with emergencies and, morbidity, mortality is much higher.
And if zone 0 is the criteria, age should be a factor, right? So if age is younger, surgical effect would be a better option than an endovascular procedure.
Once you are looking at doing a patient who is younger, I think surgical is always better in terms of what we know at this point. Maybe 15 years later, the conversation will change when we have enough data to say that endovascular is as reliable, as durable as the surgical option. But right now, ascending is always surgical as far as.
So one point I would like to raise is that historically, non-A, non-B, type A, type B, the non-A, non-B is classified as type B historically.
By Stanford criteria.
Yeah, therefore, I think we should more and more adopt that newer classification which Sky has said, so that the natural history of individual zones involvement can be better understood. So I think all of us should stick to that or adopt to that newer criteria of A and B
there are two
going by
different
zones.
TEM is
one.
No, he's
And
referring to the Sky one. The Sky is a little very complex one, so taking it a lot of help.
So
Sky is very simple. It just says the one type is A, D. D is where the distal zone is. B is very simple again. B has two notations, entry tear and extent. So it's very easy actually to, and then we can subclassify those looking at them, and then we can look at the natural history.
Types of classification. One is the clinical classification for management purposes, which includes other factors. The other is what I like to use when I look at a CT scan is something called the Dissect acronym based on Michael Dake's work, where they have, entry point, extent, dimensions, locations, every single factor, presence or absence of thrombus in the false lumen. All these are part of the complete evaluation. So all that is fine, and we know that there are soft indications, hard indications for intervening. The main issue which comes up is when to intervene is still an open question the moment you are not involving a classic type A.
Correct.
Still an open question.
Between E2 and E3, will there be a difference? Because E2 is the arch, E3 is the proximal descending in the first 2 centimeters. Would it make a difference in your decision making, Dr. George?
With what kind of
intervention? Zone 0 repair. Yeah.
No, when it's zone 0, it doesn't matter to me whether it's E2 or E3, because I'm starting.
Look at it the other way. What the question I would suppose is, if you have
E3 entry,
an entry point which is beyond the left subclavian, would you still go for zone 0?
Yes.
Depends on landing zone availability actually.
No, it is the T. I mean the extent. So you may have an entry tear in zone 3, but it is you got a retro.
That makes it that you have to cover the entire dissected part is the first thing that we agree on mostly. Though there are people who say even if you have a hematoma beyond the left subclavian, just cover till the left subclavian, not go beyond. There are people who do that still. But most of us feel that not covering a dissected aorta is a bad idea. So the zone, if your dissection is extending, the coverage will extend. There is no way to not cover it.
Now, in this, if you have a zone 2 landing, or if you need to do a carotid subclavian bypass to support, to get an adequate landing zone, is there any studies how long these bypasses last? Do you know? That's.
I think Criado has some data on that. Frank Criado. He actually when he's doing this left carotid, left subclavian, he doesn't say it's left subclavian. He says it's left axillary. He actually bypasses onto the axillary. I don't know why he says that's better than subclavian, but the long-term results are good in that.
The patency of the grafts, given that there is an adequate surgical skill exercise, I think there's not much of a problem there. But there is an issue in terms of future need for intervention, which Dr. George talks about. You will lose some access if you do that.
Yeah, the long term, we don't know.
Yeah.
Isolated abdominal aortic dissection that starts just below the diaphragm. How do you manage, or you just keep them conservatively, or when do you intervene, or any consensus on it?
I think any dissection, the same rules apply. If it is becoming aneurysmal, if it is causing malperfusion, you have no option but to intervene. Beyond that, particularly if it involves the visceral segment, which we're talking about, celiac and beyond, that's a very difficult area to intervene for a dissection because there are no simple answers yet available. So unless there is a problem, I am going to conserve. Is there any other option?
Because most of the patients, there it is an incidental finding. They just get the CT finding and come to us.
I wouldn't intervene unless there's a problem because I don't have any easy solution. I don't have a simple solution. There isn't one. I mean, even if I do fenestration, this, whatever I do, it is not simple. It's going to be problematic, and the patient is asymptomatic and doesn't have a rupture risk or a malperfusion going on. I would not intervene at all.
Okay.
The classic type B starting up there is a very different thing to intervene in. Much simpler.
We have treated a few infrarenal dissections, and there the standard EVAR is fine because it's below the renal, so you can do a standard EVAR, and it may involve the iliacs, and then preserving at least one of the internals becomes an issue. So we then use fenestrated iliac grafts to preserve flow into the internals, and we usually spare both the internals. So just like the subclavian, I believe we should always preserve the internal iliac artery.
They have part of spinal cord perfusion anyway.
And with regard to
what are the indications for intervening in an infrarenal dissection? Other than the classic ones for any dissection, is there anything else?
Yeah, here there is a new indication, that is claudication. So we have patients with infrarenal dissection and low flow into the lower limbs. So that is one indication to intervene.
And with
if you have
regard
symptom or malperfusion,
any malperfusion in dissection will require treatment. With regard to your abdominal aorta, the atypical dissection, we treat it as medical, and then in follow-up with the CT, if the diameter increases more than 5.5, it makes an indication to treat.
So at last, comment about how can registry or multicentric study improve management of non-A, non-B, IMH, and penetrating ulcer? Can we take better piece? Can we take a initiative on the national level?
I think instead of just saying non-A, non-B, I think they should probably.
Yeah, we include all
everything.
these spectrums actually, all acute aortic syndromes. And if people are willing to contribute, I am okay to start a registry. And like any standard registry, with full confidentiality of your data, your patient privacy, and of course, your data accessible only to you. And if somebody is going to be using that data for research, then only the anonymized data goes to that person from the administrator. So if we can discuss this further in the last session, but I think it's high time we had a national registry we've been discussing it, but never really done anything concrete. And this is one of the things we had initially put in the survey in the Google form also. And most people have actually responded fairly positively. So I think this is something we will take up. Thank you so much. We'll move on to
Thank you, sir.
the next talk.
Thank you. Yeah. So I think we'll move on to next session. So it's lecture on genetic risk stratification in aortic dissection and current insights. Speaker is renowned vascular surgeon from Portland, USA, Dr. Sharin Shalharp.
Hi, good morning, everybody. I appreciate the opportunity. Can you hear me okay?
Yeah, we can hear you, Dr.
Yes, Sharon, you're audible. Please go
Fantastic.
ahead.
Well,
And thank you so
yeah,
much for
thank
being
you.
here.
Yeah, thank you for having me. Let me just set up my timer so I can stay on time. So my task is to talk to you about current insights as we think of genetics in this patient population. I don't have any financial disclosures. I serve on the advisory boards
We
and
can see
these.
your slides.
Okay, let me fix that. Sorry, it's multiple. Can you tell me what you see now?
Yeah, we can see your slides.
Okay, perfect. Thank you. So as I was mentioning, I serve on several advisory board in a volunteer capacity, but I don't have any financial conflicts to disclose. So over the next few minutes, I will give you a brief overview of the genetic aortopathies, and then I'm going to talk about how aortic vulnerability exists on a spectrum. I had a chance to listen to your discussion recently about the aortic dissection, and I'm hoping that with this discussion, we'll create some cognitive changing in the way we think about these dissections. I will talk about genetic testing state in the United States, and then I'll talk about recognizing the phenotypic features that will suggest high risk in this patient population. And then I'll end with biologically informed surgical decision-making. So when we think about genetic aortopathies, the bottom line is that these are conditions that lead to premature aging of the aorta. And ultimately what you see is elastic fiber fragmentation, smooth muscle cell loss, and proteoglycan accumulation. And when I think of this group of patients, when we think about connective tissue disorders, that does cover a fair bit of the genetic aortopathies, and that includes Marfan syndrome, which is the most well described, and Loeys-Dietz syndrome and vascular Ehlers-Danlos syndrome. But you also have an increasing group of patients being recognized as having aortic smooth muscle cell variants that are also predisposing them to genetic aortopathies. And generally speaking, this population, when we looked at the University of Washington when I was there, 1 in 4 patients had a heritable etiology of type B aortic dissection. 10% were syndromic, 18% were non-syndromic familial. And what's relevant is that these people present at younger ages when they dissect. They dissect at lower blood pressures compared to their counterparts and have more retrograde aortic dissections post-TVAR, and certainly can die at younger ages compared to those with sporadic type B dissection. And so you can see here that what's really relevant in this picture is right here, this survival curve down here, where you can see that once the dissection starts, the patient population's mortality is now on a clock, if you will. So ultimately, it'll be great if we can identify these patients early on and prevent the dissection from happening or postpone the dissection from happening. But this is an important piece of information. And then when we think just generally, when I counsel patients, I tell them aortic dissections and aortic pathology runs in families the way cancer can run in families. And so 20% are expected to have a first or second degree relative with a similar history. And among those patients, of course, family history does not rule out that this is heritable because 50% of the patients are first in their family to develop this condition. And generally, the yield of genetic testing today is about 30%, which means 70% of our families do not know what they have yet. The guidelines, the current ACC/AHA guidelines do recognize the importance of heritable thoracic aortopathies, and specifically they call out Marfan syndrome, Loeys-Dietz, and vascular EDS. So if there are any of these features, and I will show you the features, then they qualify for genetic testing. But also they included any thoracic aortic disease younger than age 60 at the time of presentation that also qualifies them for genetic testing, as well as having a family history of not only thoracic aortic disease, but peripheral aneurysms as well. So they did incorporate gene-specific approaches. And as I mentioned, this is specifically for Marfan syndrome and Loeys-Dietz syndrome, because we know the most about these conditions. And obviously, things that are relevant is risk factor modification, including smoking cessation, hypertension therapy, and avoiding fluoroquinolones. And as somebody mentioned earlier, the risk of hyperlipidemia and statin therapy, of course, is important as well. However, this is what we do know as we continue to expand our knowledge in this arena, that there is variability in the tissue quality. We have seen this historically in the early literature in vascular EDS, where there are different subtypes by the type of the gene variant. And we have shown this many years ago to show that the survival is different by the type of gene. And this is really relevant because in the larger studies now in the Montalcino Aortic Consortium, there's also been variation within the smooth muscle cell variants as well as the TGF beta variants. This is an important point because whenever I see a patient, I also want to know not only what general category they are in, but what type of variant do they have, because that also impacts their outcomes. We also see this phenomenon in thoracic aortic repair with TEVAR, where you can see that there's variation by the type of variant. So this study itself did not look at the molecular genetics specifically, but looked at the diagnostic conditions of these patients and have shown that vascular EDS had the worst outcomes compared to Marfan syndrome and Loeys-Dietz. And I would argue that as we continue to become more sophisticated with molecular testing, precision medicine will advance in this area, and we're going to see that there's even more variation. And just intuitively, you already know that. Anybody who does any open surgery on an aorta can tell you that the aortas are different between different people and different ages. And you can see these are examples. This is a regular, right here on the left is a regular atherosclerotic aneurysm. This is an aneurysm with a vascular EDS patient. This is a young patient with a huge IMH and symptomatic aneurysm. And this right here is a 16-year-old who ruptured his aorta without any aneurysm. So this is the idea that the aortic disease exists on a spectrum of vulnerability, and that we do have genotype surgical phenotype correlation, where the genetic variant and the type of variant is associated with the quality or the tissue integrity. And this leads us to this precision of vascular surgery idea. And I published this conceptual framework in JVS in June of this year. So if you're interested, you can scan this and take a look at the article itself. This is, again, a conceptual framework based on natural history study. But the idea is that substrate vulnerability is variable by the type of variant, and that should help us in terms of decision making. And ultimately, I'm working on this idea of the aortic and arterial vulnerability spectrum, where we look at different things, such as the latent conditions and blind spot. Blind spots, what I refer to that is the phenotypic domain, in which I will show you some of the phenotypes. But ultimately, all of this should help us hopefully predict the future of the aorta in any patient that we see. So in terms of testing, currently we use the next generation sequencing here in the United States, and that's the gene panel, not exome sequencing. And there are limitations to that particular modality of testing, but ultimately you get variant classification that spans between benign to pathogenic, and likely pathogenic and pathogenic are the ones that you are concerned with. And obviously, as I mentioned, there are limitations to that testing. This is an issue in the US because frequently people will push back on testing and say it's expensive, but in reality, it's cheaper than a CTA, and a TEVAR can pay for 20 genetic testing. So just to put it in context, that it is affordable in this day and age. However, there are several barriers. As I mentioned, people still think cost is a problem, but really more importantly, we do have infrastructural challenges in the sense that we are not training enough medical geneticists with expertise in interpreting these genetic testing. So that is one problem currently in the US. And the other problem is the availability of genetic testing. So for example, Invitae, which was the largest commercial testing company, just filed for bankruptcy in the last couple of years and was incorporated now under LabCorp. So that is one of the challenges in terms of availability of testing. And I've been working locally at my institution to just have the genetic testing available to us internally. So the other problem is obviously we're working with incomplete information, because even if you had genetic testing available to everybody, as I mentioned earlier, 70% of the families have something, but we just don't know what they have. So things, again, that trigger you to think that this is a genetic aortopathy is age and family history. And again, as to remind everybody, 50% of the patients have de novo variants, so they're first in their family. But there are things that will suggest clinical fragility that you can ascertain from the history, physical exam finding, and imaging finding. So certainly on the history elements, on the review of systems, there are quite a few features such as easy bruising or lens dislocation. I'll show you some pictures here. And we had summarized this in this manuscript a few years ago. So let me show you some examples here. So for example, these are the characteristic facial features that you see in vascular Ehlers-Danlos syndrome. Where they have thin nose, thin lips, wide eyes, and they can have acrogyria, which is premature aging of the skin. Also on physical exam findings, if you see bluish sclera, that does suggest a connective tissue problem. And certainly ectopia lentis is a hallmark of Marfan syndrome. So you have the lens dislocation or iridonesis that you can see that finding. Other things, you can look at an arched palate that you can see in Marfan syndrome, and you can see bifid or short uvula in Loeys Dietz, although some vascular EDS will also have a bifid uvula. Musculoskeletal findings, including pectus, the abnormalities, as well as scoliosis, and then joint hypermobility, which can be scored on the Baton score. And you can see here on the bottom examples of thumb and wrist sign, which you see in Marfan and Loeys Dietz. Other things, easy bruising or very thin skin where you can see the visible veins suggest vascular EDS and some of these related conditions. And then on your CT scans, you can see excessive tortuosity, for example, or aneurysms in unusual locations. So all of this should, in addition to the genetic testing, should make you think that this is a person at higher risk or has higher vulnerability in their aortic or arterial tissues. And that leads us to a concept of biologically informed surgical decision-making, which takes into account their age and these other features that I mentioned, but also prior operations, cardiac function, frailty, as well as the genotype, surgical phenotype. And then what I mean by biological twinning is that if there are family members who've had repairs, it is useful to know how they fared from those repairs. And if they had done well or poorly with any modality, that can help you, again, counsel the patients themselves. So this is an example of a patient where you, again, are working with no family history, no other features, 56, comes in with an acute type B dissection with rupture, goes to the OR, and unfortunately suffered retrograde aortic dissection on the table and died during the TVAR. But the point in retrospect, when you look back, you can see there are features that would suggest that this is a high-risk individual, such as the aneurysms in the celiac, superior mesenteric, and iliac arteries, and excessive tortuosity. And so this, as when you're cognizant of this, that helps you with your operative planning, hopefully with a minimal oversizing and just being ultra gentle beyond what we normally do in an acute dissection. This is an example of how we think about this. We have to assume fragility. So this is a 41-year-old that came in with a ruptured chronic dissection. And so in this circumstance, I had a lot of discussion with the cardiac surgeons and had them available to us and did proceed with a TVAR. And she did extremely well and remodeled beautifully, as you can see in the imaging right here, where it had absolute healing of her aorta. And her genetic testing did come back negative. So we still don't know what she had. But obviously, it helped us at least to assume that she had something in our planning. This is the other end of the spectrum where you have a 70-year-old, and usually you think, okay, 70-year-old, it's atherosclerotic in etiology perhaps, but this person also had visceral aneurysms at the time of dissection, and they underwent a zone 2 TBE, and then subsequent embolization of the visceral aneurysms. However, and was discharged on day 7, great, but by day 8 developed retrograde IMH into the ascending aorta that required repair. So the risk is still there, even when it's not quite obvious. And then I would say in yellow, I'm highlighting the visceral aneurysms as being the red flag in this case. Retrograde aortic dissection can occur in a very delayed manner. This is a case of Marfan syndrome that was treated with a TVAR many years ago, and 9 years later suffered a retrograde aortic dissection. So the risk is always there. The arch is really unstable in this population. And so preferentially, I prefer that we stabilize the proximal landing zone through the arch itself. And depending on the presentation of the patient, this can be done in a subacute manner, meaning they undergo the TVAR and then stabilize them and then have the arch repair in a delayed manner. And in some people, if it's in a subacute phase, they can have the arch repair and then a frozen elephant trunk. The other thing is to think about is as we place these devices, we want to think about stent graft induced new distal entry tears. Certainly, I think this population is at increased risk. But the other thing is we do know that the hemodynamic parameters have shown that depending on where you land your distal TVAR, the distal portion of your TVAR, if you're in a bend or a curve, that increases the hemodynamic forces. And so my recommendations, obviously, when we're planning this, is to take the curve in that distal portion. And also the other component is that when the device is short and it is basically directing all the flow towards the outer curvature of the aorta in zone 3-4 area, that can accelerate potentially the aneurysmal degenerations. This is a case with Loeys-Dietz syndrome, a 22-year-old with Loeys-Dietz. And so do take the curve. And this is another exact question that I wonder, this is mostly for discussion, about are we accelerating the heart failure in this population, particularly in young individuals when we're putting in these stiff TVARs. So this is a 22-year-old woman, again, with Loeys-Dietz, and she obviously has coverage up to a supraciliac section. And obviously we'll have to see what time shows over time, but that is something I am worried about in them. In children, I think it's important to account for somatic growth. These kids are going to grow, and this is an example of a child that at age 9 had a large arch aneurysm, and this was fixed with an open repair. And at the time, the team chose to put a iliac limb in a frozen elephant trunk configuration. This was around the time when it was very popular to think that FETs will promote aortic remodeling or set you up for the next stage. The problem with that particular approach in this child is that he developed a type B dissection now at the age of 18, and aneurysmal degeneration, as you can see here, distal to that iliac limb. And the iliac limb was quite small and didn't account for the growth of the child, so who's now a teenager. And when unfortunately that limited a lot of our options in the acute phase due to a lot of reasons, was not a candidate for an open thoracoabdominal repair. So unfortunately, I had to do an aortic debranching in the abdominal aorta and then extend the TVAR. But he does have heart failure, and this is why I always think about, like, are we hurting this population in the long run when we put these TVARs? So I'm happy to say that we have a few minutes for discussion. So I'm going to close my thoughts here by saying that we have to think of the aortic vulnerability as a spectrum, not as a binary state, not genetic versus not genetic, but really as a spectrum. And there are features when they're younger and they have extra aortic phenotypic features. You want to think that there is hidden suspicion, or that there is high suspicion for hidden risk. Certainly, the genetic specific outcomes have been reported to date. The data are limited, generally speaking, but for FBN1 and for Loeys-Dietz genes, we are beginning to have more information. I do want to think about the long-term outcomes and, again, pay attention to the device choices when we do that. We are hosting the inaugural Vascular Genetics Symposium in October of this year. This will be a full day of genetic aortopathy education where people will learn about each of of these specific genes and what that means in terms of their outcomes in their natural history study. And we kicked off our first meeting of the Vascular Genetics Consortium, which is where we're trying to harmonize data across multiple state institutions here in the United States to see if we can get more information that's collated about these different genes. And I appreciate your time and attention, and thank you for the opportunity to join you today.
Thank you, Shireen. That was a great talk. And to set the ball rolling, 2 questions. The MAD symposium, the full day symposium, is it only in person or do you have an option to attend online?
It's at the moment, it's in person, and we're starting small. So we're opening this only for the fellows. So this is going to be senior level fellows. Very few faculty will be attending. It's just mostly for the fellows who are graduating. If things go well, God willing, and it's successful, then we have to think bigger. But I do think, as you saw now, we had 20 minutes to give this talk. I really feel that that is not adequate to get into the nuance. I think people have a high idea of the discussion, but really, I want us now to get more sophisticated when we talk about precision medicine and really start to understand the differences between these different genes.
And so if you have a patient who does not have any syndromic features clinically, and we identify something on genetic evaluation, what intervention can we do to people who have been asymptomatic in the family, and to somebody who's had a dissection and we have treated, what can we do to prevent disease progression or onset of disease in such groups?
Thank you. So everybody gets the same spiel from me, which is blood pressure has to be tightly controlled. So I keep them less than 120. If they have hyperlipidemia, we're treating that. I tell them if they ever need antibiotics, they should never get fluoroquinolones. That's just based on the FDA black box warning. I do prefer, if they need to be on antihypertensive agents, to put them on beta blockers, and if they need a second agent, an angiotensin receptor blocker. If they naturally run low on their blood pressures, I'll start them on an ARB and then can see how they do with that. Calcium channel blockers have been shown in animal models to increase potentially the growth of dissections or aneurysms. So I tend to use that later in the sequence of events. So that's just, how we think about their antihypertensives. If they're smokers, they need to quit smoking. They're not designed to be smokers. So all of these should hopefully help them, because I highlight to them, it's like, if you have a dissection, the clock is ticking, and we really want to delay the onset. Even if you're at risk for dissection, ideally, maybe you'd never have a dissection, but if you have a dissection at 90, that's better than having a dissection at 50. So we want to do that. So everybody gets that same spiel from me. Vascular EDS has additional things, like I put them on vitamin C, I put them on zinc, cofactors for collagen production. The other thing I started doing now experimentally, and I mentioned it in the paper that I mentioned, I'm doing skin biopsies now to look at the elastin and the collagen structure in the skin, to think about the skin as a window into the aorta, where it can help us see the abnormalities that the patient have. Is this an elastinopathy problem? Is this a collagenopathy problem? That may also help us sort of bypass this waiting for the genetic testing data to catch up. We are years away from identifying all the genes, but the skin biopsies are available, electron microscopy is available, so that may help us expedite trying to think about these patients a little bit better.
Yeah, Dr. Sharad?
Yeah. So it's extension of same question. So no phenotypic features, but genotype positive. How often does that change the planning of primary procedure?
It changes it in 2 ways. So just because you do not have phenotypic features doesn't mean you don't have a genotypic susceptibility. And particularly if you have the genetic testing that shows that you have this, then that is useful information. So if it is one of the Loeys-Dietz genes, we have guidelines that suggest repair at smaller size thresholds compared to Marfan syndrome, for example. So that is useful. Some people with Marfan syndrome or the FBN1 gene don't have any phenotypic features. They don't look anything like classic Marfan. But again, if they already have the genetic testing that shows FBN1, then I treat them similarly like that. Smooth muscle cell variants are also interesting in the sense that we don't know enough about when to treat them with more nuance at the moment. But I do think any of these genes make you start thinking of a lower size threshold for repair. And it makes you think more thoughtfully about how you're going to use TVAR in that population. So again, if it's a TGF-beta pathway pathogenic variant, you have to think that the arch is going to be unstable in a TVAR in that population. So that's how it changes your approach.
Dr. George? Ajay, Shiva?
One quick.
Yeah.
question.
Rohit.
Yeah. Thank you, Dr. Sharma. I just want to have a quick question regarding a specific genetic, like the Louis syndrome. Is it Louis-Dietz syndrome? My question is it any different with regard when you compare to Marfan's and Ehlers-Danlos? Do you think I know the aorta becomes aneurysmal or dissection, but my question is, do you think the juxta-ostial visceral arteries are okay, and Louis-Dietz has got more peripheral, very distally they have problems? Like in the sense, if you were to think an hepatic artery at the ostium, it's okay, but within the organ, is it a bit different from the others?
So in Louis-Dietz right now, there are 6 subtypes. Type 1 and 2 is TGF-beta receptor 1 and 2. They have a very virulent disease. They manifest in childhood. They can have multiple visceral aneurysms. That 20-year-old I showed you, she has huge hepatic aneurysms that we've treated. She has subclavian aneurysms. So they do have that. It's more aggressive. Marfan syndrome, 10% of the population with Marfan syndrome can have peripheral aneurysms, but it is nowhere near as aggressive as Louis-Dietz. So Louis-Dietz is particularly aggressive. Vascular EDS is similar to them, but also different because the tissue is far more fragile in type 3 collagen defects, the vascular EDS. When you sew on them, they're far more fragile compared to Louis-Dietz. Louis-Dietz tissue can handle sutures. You can put sutures, you have to use felt, and you can operate, but it doesn't fall apart in your hands. Vascular EDS will fall apart. So they can be different.
Just one more question, Doctor. Is with regards to measuring, I had talked about it yesterday. Do you think measuring for devices or graphs for this subset of patients, it has to be different compared to the routine measurement? Because what happens is most of us are still measuring the aortic size and all, but we're not looking at what's the body surface index, what. So do you measure them completely different compared to your other subset of patients?
So let me preface. When I say yes, different, what I mean by sizing, like if I'm going to do a TVAR in that population, I'm almost going to do a 1-to-1 ratio with no oversizing. But the measurement itself, we still measure similar to the classic way where we're doing diameter measurements, right? That said, I mean, and this is a bigger discussion for like looking at body surface area. And I don't like body surface area because in America, a lot of us are overweight. So that's not useful. But maybe adjust the height, because if somebody who is 5 foot, somebody who's short is different than a football, a basketball player, right? Who's really tall. And so for women, for example, or petite people, you have to factor that into that formula when you're measuring them. But I don't think that that's different for genetic versus not genetic in terms of absolute size when you're thinking about size thresholds.
Thank you.
Any other question or comment? I think that's it, Shireen. Thank you so much for being with us. We really enjoyed the talk and the discussion. And
thank
you sometime. Thank you.
All right. I appreciate you. Thank you. Enjoy the rest of the meeting.
Thank you, Shireen.
Bye-bye.
So we have a few companies in India who are doing genetic testing, and they have representatives in most of the cities. And I think these companies a couple of them at least are based in Bangalore. And if you give them a call, they can send the rep home, they collect a blood sample, and they give you the report in a couple of weeks. And they do the complete sort of genetic finding. I'm still not sure how to interpret these, because we test for one thing, and we've been specifically testing for venous malformations or peripheral arterial aneurysms, and we get something which is totally unrelated. And that is the point where we really get stuck. How do we counsel the family with that? So we really need to train the geneticists with us in the departments who can actually tell the patient. So we had a patient who had a peripheral arterial aneurysm, and in the genetic testing, they gave us a gene which put the patient sort of more prone to have some lung surfactant disorder and stuff, and we really didn't know what to do with it. So we are trying to identify pediatricians who have some interest in this, some genetists. We had actually invited one lady to come today, but she had to travel to Chennai, so her talk was cancelled. So because genetic counseling really becomes important once we start testing for this, because things will come up which are totally unexpected.
There is to answer. There's actually that there's at Aster Medcity, we have got a few patients for genetic we sent. One of the companies is actually Hyderabad based. It's called Map My Genome. So they are the ones. They are like MedGenome. MedGenome is what we have been sending to, but Map My Genome, which is based in Hyderabad, is a bit different. What they do is you send the patient's details. They will fly down from Hyderabad to wherever your patient is. They will do the counseling. All the payment, everything happens with the. It is slightly expensive. It happens with them, but the important thing is after they are diagnosed, they have got the not funding, whatever whatever the authority to keep them to connect them to patient groups across the world. So it's the same like MedGenome, but Map My Genome is a bit more of a what do you say, less money making, but more this thing. So Map My Genome is one. It's very popular. To answer your question, in India, Map My Genome, MedGenome. These are ones who are doing genetic testing for the.
And there are patient groups in the US, and I think they are open to our patient population also.
Yeah.
So if you have somebody who comes up with Ehlers-Danlos syndrome or Marfan's,
Yeah.
they can actually be part of those patient groups or societies and gain from that association.
Yeah.
If you want, I can probably ask Sherin and connect your patients to those groups.
Yeah, we've been doing genetic testing now quite regularly for all our younger patients and where clinically we suspect genetic disease. And the results are astounding, because now we have a name for the disease the patient has. Otherwise, query genetic and we just go along. But now I know this is the SMAD variant of Louis Dietz that I'm dealing with. I have it absolutely precisely. It makes a huge difference. And then we have a medical genetics department, so they get counseled. So it's now much more rigorous and scientific the way we approach this. And it's not very expensive. It's 19,000 rupees for this. And we then do first order relative screening. And it makes a huge difference for the way they plan the life ahead, So yeah, so no, the testing is done elsewhere, but we take the sample in our hospital. So it's quite convenient. And then when the results come, they go to our medical genetics department and they get counseled. So it really changes the way we look at it. We now have names for each of these, and you can see the difference, between them.
It's something like when I was training in surgery. So whenever our patients died post surgery, so it was already acute MI or PTE. We never knew what the real cause was. Whereas on the physician side, whenever a patient died, they always sent for autopsy, and they always knew what the diagnosis was. So it's something similar. We do the genetic testing, we know what we are dealing with. Otherwise, it's pure guesswork. So shall we move on to the next, the last panel discussion? This will be, again, some things that were discussed yesterday, addressing visceral ischemia, limb ischemia, and then a choice of therapy for chronic aortic dissection. Girish is here, left. Ajay, Siddharth, Narendra Meda, Karthik. Pradeep, would you like to take this place since Girish is not here? Or Rohit, you can come. We need somebody from Maya. I think you all are familiar with how to go about it now.
So we move on to the panel discussion on managing complications in aortic dissections. So first addressing visceral ischemia. The first point is how do we effectively diagnose cases with visceral ischemia? What is the most effective diagnostic tools in the acute phase of aortic dissection? Dr. Rohit.
So here we had, yesterday we had a bit of a debate. What are the most effective diagnostic tools for detecting visceral ischemia? And there's a lot of onus on clinical thing. So on that one aspect, myself and George sir agreed that clinical may be a bit too late. So there are easier, see, we are moving forward with technology. So my question is, why can't we use that to detect these things or the high risk patients early? So simplest thing I would say, obviously, clinically is very important and all the other markers are important. But as a intervention radiologist for us, what we do is a very simple, not even CT scan, a very simple ultrasound. You can measure the peak systolic velocity. You can measure the flow. You can measure the spectral broadening. That gives you an idea, an early idea. Okay, this particular visceral artery may get compromised. You get a 50 to 60% idea. So a simple ultrasound is more than enough rather than going for a CT. I mean, if you want to CT scan, doing FFR, all this stuff comes at a later stage. But the earliest thing I think for diagnosis, just a simple ultrasound would be enough for to understand visceral ischemia. My worry is that we wait for clinical signs to happen. It may be too late.
Can you be very confident of this ultrasound when the patient has abnormal, a little bit of distension, gas and things like that? No, your visibility is poor, no, ultrasound.
Usually, no. See, if this gaseous distension, it's already too late. Maybe if it is visceral ischemia, but otherwise, all what you have to look at is if you can go transhepatic to see the SMA or trans pancreatic. You can do. There are different ways to do nowadays. The ultrasound with the machines that we have, it's actually not that difficult. Yes, it is challenging when it's a big abdomen. You're not able to see the artery in complete. But see, in dissection case, like you're expecting it to there should be some compromise in the first 2 to 3 centimeters, first 20 to 30 millimeter. That you should be able to see with a simple ultrasound with the machines that we have.
I think Rohit, yesterday, Shuvrai was very categorical saying that CT is 100%, you can get the diagnosis.
No, I agree. What I'm saying is, the question here was, what are the most effective diagnostics for detecting visceral ischemia in the acute phase? So, I mean, to start off with, I was just saying, because, there was a discussion yesterday saying that we cannot shift the patient to CT scan. It is too. So, bedside, what can we do? You can do a bedside.
No, I think for all practical purposes, dissection is diagnosed most of the times on CT scan.
Agreed. Yeah.
I think, and my problem has always been when it comes to mesenteric ischemia, the decision making, yesterday a lot of discussion happened. Coma and mesenteric ischemia is something which, might, push the surgeons away from doing a primary central repair. I think at least that is the gist I got from yesterday. I would not be 100% sure on CT that there is a established mesenteric ischemia. Yes, there is a fixed occlusion, it is easier. But if it's a dynamic occlusion, based on the bowel enhancement and all these things, if there is a obvious sign, it is easier. Otherwise, it is difficult. It is actually very difficult for all practical purposes.
So in terms of the practical purposes, so I practiced for 5 years at Stanford, and we, as somebody mentioned, work with Mike Take. So the question we had is in terms of acute phase of aortic dissections, the protocol we had there is one, as he mentioned, we have a dedicated vascular lab technician there. Of course, the ultrasounds are done by our technicians, where most of it, we have a dedicated aortic lab technician. The problem we have with, it's easier to say in terms of diagnosing at bedside. The problem is training for the, the tech availability and the reading and those things in terms of how the dynamic and those things. And the first thing we go by is we do labs almost Q2 hours for aortic dissection. The first sign we watch for in terms of mesenteric ischemia, which in our studies have shown 63% of more mortality, obviously with the mesenteric ischemia. The moment the WBC count changes, we actually don't hesitate even for ultrasound. They go for a CTA, whether, most of the times the aortic work, they do have the CT within the floor and they get shifted. And as you said, we cannot see the dynamic version of it. And also by the time you find the changes on the gut in the CT scan, it's already too late. So I do agree with that, to have a protocol to establish dynamic ultrasound on bedside that can be evaluated with a simple measure. If you can train the techs, or even I think the radiologists do it here in whatever way, I think that actually is the first sign in detecting visceral ischemia. Of course, the renal, there are many other ways to do it. And somebody mentioned yesterday in parking a catheter. That again is a problem in acute aortic dissections, because you have to use IVs and they're unstable, and you actually have to shift them to a cath lab to measure the changes in the peak systolic pressure. Actually, ultrasound is much better if we can train and have a protocol combined with labs that we can follow.
So we can divide, I think, this situation into two groups. One is where the patient has a imaging feature suggestive of a stenosis or like kind of static SMA.
Or a radiological only.
Radiological. And now the question is whether you want to treat it or not, because patient doesn't have a clinical symptom. So we can take a help of ultrasound, which can further guide that there is a dynamic effect also is there. Another group is, of course, clinical, where patient have frank symptoms, or where we have a ABG blood gases on and the CT showing that images that bowel is edematous and blood gases are going, lactates are getting elevated. So that will, these two groups are to be differentiated.
Then, however, what Mr. George's sir is telling, diagnostic lab, if someone is a, you have a doubt on ultrasound where we can't imagine, do proper imaging, like Shekhar sir said, distended abdomen, all these issues. How can we do a diagnostic lab to look for a mesenteric ischemia?
I mentioned that yesterday, diagnostic lab cannot be foolproof because you may not be able to visualize the entire gut.
No, the role of the diagnostic lab is not to exactly diagnose. It is basically to whether you want to do laparotomy or not, actually. If there are changes, you will go for laparotomy, actually.
Then the key crux of this question is how to diagnose it early enough so that you're preventing a bowel damage level of ischemia. So I think
can we just flip it the other way? I think numbers wise, for example, Dr. George Joseph, you would have had acute dissections treated. You have actually did the, the TVAR or the open surgery, whatever was done at that time. How many patients actually subsequently ended up with mesenteric ischemia? I mean, it's just, experience counts here. I think that is what I'm asking for.
We've had a few patients with mesenteric ischemia, which we either went for surgery or we did TVAR, and then subsequently we started seeing these features of mesenteric ischemia. The problem we face is by the time you get clinical features, it's already too late. And when they went for laparotomy, they resected a huge amount of bowel and all of them died. Not a single one has survived. So the problem I see is we were too late. We should have either sent for surgery much earlier, but then you have a problem convincing the surgeon to go in, He will say, no, let's wait. There is no definite feature. And by the time we are all agreed, okay, let's go for laparotomy, it's too late. And none of them survived. So I think the few that did survive is where we went in and fixed the superior mesenteric with a stent ahead of the TVAR. At presentation itself, from the CT, we realized this is going to be ischemic. We went in and did a superior mesenteric stenting, improved the flow, then either went for TVAR or went for surgery.
I think probably the next question is probably how to deal with that.
Correct. So the next question is on how should we prioritize visceral malformation in a management of complicated aortic dissection, and what are the preferred interventions? So do we treat the aortic dissection upfront or the visceral malformation upfront?
So yesterday again, it's a decision. I think what I get from the cardiac surgeons and vascular surgeons, that if there is a threatening visceral malperfusion, see, this is is it visceral malperfusion as mentioned, or is it visceral ischemia? Malperfusion. So if that's the case, what I understood is that you have to try and tackle that first before you treat the complicated aortic.
The renal, they're okay.
Renal okay, but the bowel.
Bowel is
Can I mention a point on that? I think we know that 80% of the malperfusions are dynamic mostly. So we can still go ahead and do the aortic primary entry intervention first, and then assume that this will treat this.
I'm asking, see this, suppose let us see the SMA is arising from the false lumen. Patient is not ischemic, the bowel is not ischemic, SMA is arising from the false lumen. So at this stage, which will be your first one? And if you want to do the SMA, how are you going to do that endovascular?
Fenestration. Fenestration is preferred, but most of these are dynamic and acute aortic dissection. And before, yeah, the static you have to stent, but the dynamic ones we do prefer fenestration.
I think the question here is if it's from the false lumen. I think there's no problem. You stent into the false lumen, let the flow start. And then after the primary repair is done, then you may want to do some further work like penetrating the plaque.
See, after you fix that tear, the false lumen thrombosis means this also is going to thrombose.
Yeah,
No,
so you got to have a good true false communication at the level of the SMA if you have stented the SMA at the end of the case.
Usually, sir, that's true, sir. I absolutely agree with that. About 60% do have some sort of re-entry test, especially at the renal ostium. And then you have that, this thing.
Yes, sir. Always there is re-entry point. So even if you address the proximal entry tear, the false lumen filling, unless it's a rupture where you want to entirely tackle the false lumen leak, here only we're improving the true lumen flows. So if you tackle the false entry tear, so the re-entry, there will be always flow through other vessels.
I fully agree that it doesn't clot completely. Yes, but then still the flow in the false lumen definitely reduces.
Not at the SMA level, sir. I don't think so.
There will be good entry tear at the level of celium mesenteric levels. And also, always the left renal artery is from, predominantly it is right renal, celiac SMA is from true, left is from the false. And when we do left renal never goes for malperfusion. When we address a true lumen, through the false lumen, left renal artery keeps.
I think it's not assumed, Dr. Shekhar sir, I think it is not assumed because it is coming from false lumen. If you fix the central dissection, that there will be visceral ischemia. I don't think that's the fact.
I agree that the false lumen will continue to be patent in the visceral area. It doesn't thrombose immediately. But the flow in the initial period definitely reduces. Because the majority of the leak is coming from the top, not from the bottom.
It may not actually become symptomatic.
Yeah.
Yes, that is why whether it's wise to try and do an endovascular or go for a surgery where you can do a bypass and make sure that the visceral artery is perfused properly.
So in the absence of visceral malperfusion, it's a big ask, I think, this is what I was thinking, my experience. If there's no, see, the question is, how should visceral malperfusion be prioritized? So if there's visceral malperfusion, then you have to fix that first, primary to this thing, yeah. But if there's no visceral malperfusion, or you think it can happen, I think it's a big ask to open or do a stent. Yeah.
So what are the techniques, for example, SMA? What do people follow? If there is a SMA with, coming from false lumen, what are the techniques that generally people are, because I have not done that many. So how do you deal with them?
No, if you have multiple entry tears at the visceral level, we don't usually do anything unless if patient is not a significant malperfusion.
I think we are assuming that there is a visceral ischemia, malperfusion.
We should always do a fenestration.
So where do we do it? At what level and where do we do it?
There's the visceral SMA level. Most of the times we do it with SMA level. Then you check with the angio. If it doesn't work, then you just put a stent there.
This is where the pressure measurements FFR makes a huge difference. You go into the true lumen, you measure the pressures, you go into the false lumen, measure the pressures, and get into the SMA finally, because that will be where you want to this thing and measure the pressures. So it is very important, because what you have to see actually is what is the pressure grade, has the pressure grade reduced after you're primarily treated, may it be flap fenestration or stenting. But flap fenestration is, I'm not very sure about, see, flap fenestration is something which we like to do, and we do occasionally with this, but I don't know how effective it is.
Rohit, if we need to stent the SMA, how confident can we be that we can enter the true lumen of the SMA definitely in a static obstruction?
So see, that's a big ask again. See, I find it's very difficult and a bit, you have to clench your buttocks quite tightly when you're doing it. Because it's very, it's very.
And even with the fenestrations, we have noticed sometime, at this point when the patient is sick and everything, and you've reached the fenestration part, we have to just establish a communication between, not necessarily the SMA level. We have ballooned it. We haven't even actually stented the fenestration itself to keep the channel open rather than going into the actual ostium of the vessel, and that sometimes work.
And quite often on a practical note, these patients already have some level of abdominal issues, and we end up doing a laparotomy to assess the bowel. So I think in that case, many of us end up doing SMA bypass, well, honestly.
Bypass, rather than trying to do endovascularly in this situation.
Sir, my question, which is better again, fenestration is better or doing the TVAR to address the malperfusion? We always end up with this kind of doubt whether to fenestrate, because fenestration, I don't think it's increasing the
Flow in.
we have tried, sir, but.
So when we are doing a fenestration, we always do it after the TVAR. So we do the TVAR, reassess the situation, and if you still feel the SMA is.
If I have to get different scenario, what Dr. Dinesh is.
Doubt is mainly because the acute carries high chance of retrograde dissections. So there to tide over, like just do the fenestration and come out. Why to put a TVAR? Fenestration alone will work, or as you said, ultimately we had to take a plan.
Yeah, so if you feel that fenestration alone is required, then by all means do it.
No, I can ask one more in another way to both the thing. If there is obvious visceral malperfusion in a dissection. So the question Shivanesh was asking is, when you come into the scenario, okay, should we treating the primary tear, if that addresses visceral perfusion, that's fine. But if there's a frank visceral malperfusion on CT or clinically, but we're not sure whether we should fix the primary tear, would you do something that, would you address that first? Which is what the understanding is, we should address that first. What do you think?
No, so it is either, is it dynamic or is it static? So if it is a dynamic thing, it's usually related to, you need to do the primary tear first.
Static?
If it's static, then you got to go in and put in a stent.
First, before you?
First, yes, absolutely.
So that's agreed upon. So on to the next question.
There's just one more point. This fenestrating that flap.
Yeah.
There are different techniques.
Yeah.
We used to initially just cross from true to false or false to true and just do a balloon dilatation.
Yeah.
Now, sometimes that doesn't work.
Yeah.
So now we've started a new technique. It's called the electrosurgery, basically.
Yeah.
There is this wire
which
you have catheters on true and false side, and there's a wire crossing from true to false, and then you electrify this wire. And just pull that down. You get a very neat cut, and exactly where you want it.
Yeah. So that is actually, if you go to the next one, is what are the outcomes of endovascular fenestration / septotomy versus stenting for, we'll discuss that and then we'll come to the next, which is just saying. So what are the outcomes of endovascular fenestration / septotomy versus stenting for visceral ischemia in aortic dissection? What do you think? What are the outcomes of endovascular? So what is better is what the question says.
Again, as he said, for dynamic, you actually do fenestration. For static, we do stenting. But I think the question we can take it at a different level is this versus an open repair is something which most of the societies have talked because the Thoracic Society says you should go for open when you have fixed that and the acute phase has passed, no matter what you have done in these phases. And most of the vascular societies and the cardiology societies, the AHA guidelines say once you do the fenestration for dynamic and stenting for the static, you can just observe and see as long as you have fixed the primary entry tear. So the discussion is whether, the outcomes of these are equal. Once the visceral ischemia sets in and you have done this one, the mortality is 60%. But if we have actually intervened before, it comes down to 10%. So it's better. The outcomes are decent. Now the question comes, when should we do surgery or should we leave them this way is the question.
The sir was saying that he would prefer a bypass, but how easy it is.
I was very upset that the option of surgery was not there.
Yeah.
We should have.
We put it.
Surgery that. I am voting for surgery, which is more
How-
definitive.
My question is, I understand, sir, how, just as a debate, it's not about decision, as a debate, how easy it is for to open up a acutely dissected aorta? Is it?
No, here we are not touching the aorta at all.
It will be an iliac to femoral bypass.
We take it from the iliac, whichever iliac is free of dissection, we
Yeah.
take it from there.
Yeah, and
So we don't touch the aorta. So it's a bypass to the SMA.
so what if you have the dissection going all the way into the, let's say, the mid or the distal SMA?
That you can, at a vision, you can.
Yeah, we to identify the true.
Fenestration. You can do a fenestration there, fix it up and then do. Then much easier. We don't touch the aorta, open, so.
Yeah.
So it's much easier.
So the American Association of Thoracic Surgeons agree with you where they say if you're going to do this one, but from the practical standpoint is like, when, the surgery is again very invasive and the patient is already sick and those things, whether we just improve the flow with the stenting or the fenestration and then observe the patient and you fix the primary tear, or what would be the timing of the surgery if you were to do this?
Now you're trying to do stenting to fix that SMA. So you want to advise surgery when it does not work. So you're losing so much time. So the moment you think there is a stenosis or a dynamic obstruction to the SMA and there are likelihood of an ischemia, I would suggest that primary surgery is any day better than instead of fiddling around with an ostium which has an inflammatory flap, and you may enter either the true lumen or the false lumen may make it worse. Suppose you put a stent in the wrong lumen and the dissection extends up, it makes surgery also difficult.
I think the challenge yesterday, the discussion hovered around when it was type A plus mesenteric ischemia. I think if it is type B with mesenteric ischemia, as Dr. George Joseph mentioned, or even Karthik was telling, was maybe quickly do a TVAR, because it is quicker to do and not much of time is lost, and reassess the situation there. I think type A is where a lot of controversy is there because the morbidity and the mortality outcomes are much worse if there is a established or threatened mesenteric ischemia. I think if it is type B, doing a quick TVAR proximal hole closure and reassessing on table probably will be a trade-off.
The problem here is if it's type B, for Dr. GJ, then he will go up all the way to zone 0. So it'll make it a bit more complicated than a simple stent.
No, we have done type Bs where we first stented the SMA and then took our time and did the primary repair.
Yeah.
So it's very important to identify what is causing the SMA ischemia. Is there a dissection in the SMA itself? So then whatever you do primary or whatever you do, this is not going to improve. So you need to go in and put in a stent or maybe do a bypass.
Okay.
So that is very important to
first
find out.
First sort that out first.
Yeah.
But the next question is how can because we're running a bit time, how can intraoperative strategies reduce the risk of visceral ischemia during open or hybrid procedure? But I think more than that, you were telling about intraoperative when I interrupted. So can I just rephrase that? What are the intraoperative strategies you have to reduce the risk of visceral ischemia of GJ, Dr. Girish, and also surgical side?
Yeah, so basically, we use only two. One is we just do a balloon dilatation of the flap with a wire crossing from true to false or false to true. The second is if that doesn't work, if the flap is thick and all, sometimes that doesn't work. Then we do this slicing the flap with a electrified wire. Earlier, we used to just put a 014 wire and try to pull it down. That is described by somebody called Beregi years ago. But the problem with that is it just bunches up that flap and creates one mass there, It's not effective. So whereas this electrified wire really beautifully slices through without any bunching up of the intima. So we've done that in a few cases.
Let me ask you, George, what happens to these patients? See, you are wanting to cover all the leak point. Now you're creating a bigger leak point. What happens to that later?
No, so this is in the abdominal aorta. So entry tear is way up there. That is going to be treated with a endograft, and that's coming down to the level of the celiac artery. So the rupture usually is up there in the thoracic part. So that part we have excluded. Now you may have a retrograde filling of the false lumen from below. Now, if that is acutely a problem, you got to think of a candy plug. Now, if it is not an acute problem, is down the line, the aorta is growing in the abdominal aorta, then we do a completion repair. And we go all the way down to the iliac artery with a 4
No,
fenestration.
that's what I'm asking. You're creating another tear in the vessel
Yes,
area.
yes.
Will it not produce a bigger leak and
It might.
aneurysmal dilatation?
So it might further the aneurysmal growth of the abdominal aorta, but you have saved the patient from bowel ischemia.
You can also do that with surgery.
Sure. So if you can do it surgically, that's fine.
So what balloon do you use for that penetration? What size balloon?
Up to 20.
20.
Yeah. Yeah.
It's a problem sometimes what we face is a generalized true lumen size is very small. It's not a visceral ischemia or visceral renal. There is a less flow to both the celiac SMA and one of the renal. Only one renal will be perfusing. Patient will be having both the combination of both visceral. There, I think the best option is to do the entiter do a TVAR or fenestration. Isolated SMA, we have done most of the cases retrograde SMA bypasses. They do really well.
Let me just tell you an anecdotal case. I mean, you can't learn many things from that. This man, that's why I asked that question yesterday. This chap came with a type A dissection. He was stable. He came after 24 hours. He was stable. When we saw him, the first symptom that he gave was the leg pain. So we found the dissection entering into the iliac, that the right leg was severely ischemic. So we just did a fenestration for that. And then that improved. The leg.
How did you do that?
It's only blind tech in those days. I'm talking of is 25 years ago. With the robotic catheter, we just ruptured it. And next day, he started complaining of abdominal pain. So I did an iliac to SMA bypass for him. And the bowel completely recovered, no problem. And he refused any cardiac intervention. He went on to live for 1 year. At the end of 1 year, he came with ascending aneurysm. That time, elective surgery was done. And he survived to live his normal life.
Yeah, so open bypass was, and as you said, creating fenestrations or stenting. What are the? Yeah, please.
So I think for want of time, we'll move on to the next topic that is on limb ischemia. First question being, what is the clinical signs and imaging findings that guide you to diagnosing limb ischemia and acute aortic dissection?
Open the pen.
So, sir, if the patient is having the flap going into the common anal, patient is a claudicant, like how you would like to treat this patient? Would you like to stent in isolation, or it will be like that proximal tear will also be sealed actually?
So again, it's quite similar to what Dr. Gigi said, that I mean, you can fix the primary tear, whatever, but if this is more important, you need to sort that out first before you fix the primary tear. So fixing the, I see, this is slightly different from visceral ischemia is what I think. Dr. Girish, this is slightly different from visceral ischemia, because usually visceral ischemia, if you, as you said, sometimes fixing the primary tear might solve it, or we have to do something else. But I don't think in any case, fixing the primary tear up in the thorax will improve the, it has to be something more local. So I think what do we, what are to answer the question, what are the key clinical signs? I think most of us know. What are the imaging findings? So how many of us do ultrasound? You see, this is why I keep on telling, it's such a simple tool, bedside tool. It just gives you on the spot diagnosis, whether this is ischemic or what are signs, what are chances. So that, what are the imaging? I would say the first thing is ultrasound to do. Okay, then we'll talk about.
I think that is agreed upon. I think most of the aortic centers that have a dedicated aortic person, as I've mentioned, for both viscerals and also legs. And in terms of, we see this often, both one is a type A dissection going all the way down to the iliacs, or the other way, type B going all the way, we're fixed, we're fenestrated, but we haven't really addressed the legs and they complain, either by claudication on post-op day 3 when they're up and running. So as mentioned yesterday about the Rutherford's classification, everything, unless there's, you see the clinical signs of deterioration of tissue, limb loss, or those things, we usually, if it's just claudication, they go about it and we observe them and then see them in their office. And if it's still going, then you address that isolated with a stent. But we haven't, unless, most of the times if it's visceral and then we have fixed it, we haven't really gone after the limbs just for the sake of it.
I think the experience what we had with the limb ischemia is unfortunately when the initial presentation itself was, loss of movement and things, that was a bad way to present. And if my memory is not bad, I think it was within an hour. It's just a bad luck of the patient. And when we did the primary closure, everything just opened up like water flowing from the dam.
Okay.
But obviously it was too late.
Yeah, too late. Yeah. So when there's no lymph movement, I mean, in an aortic dissection scenario, we're talking one, it could be as is it an occlusion or the false lumen completely thrombosed going to the limb. Or the fact also you have to consider is because of dissection paraplegia. So it's very important to understand what is the cause for, as you said, limb loss. You said you said you had pain, right? For your patient.
It was obviously ischemic with no signals, no
obviously
limb movement.
ischemic. Obviously ischemic.
See, so we may have a scenario also like where ischemia led to spinal cord ischemia, patient presented with the paraparesis, and we presume that imaging is showing that there is a flap going into the eye, like it is ischemic actually. So how you would go about that actually?
So we have had a few patients who have come with acute lower limb ischemia with threatened limb, that is the presentation. Now we found that the false lumen at the aortic bifurcation has a good pressure. Okay, so there all we have to do is connect the false lumen to the true lumen in the lower limb with a stent, bare stent, and the limb is saved. Okay, so we shouldn't hesitate to use the pressure in the false lumen in the lower abdominal aorta to perfuse the limb. So we shouldn't be stuck with the thing that, oh, that is false, it's not true.
Sir,
so I cannot.
Sir, can I just interrupt here?
Yeah.
That scenario here with limb ischemia, if it's a type B, what we felt was, that experience was, the moment you close the top hole, we didn't have to do anything.
Fair enough.
Because it was whatever 2 cases we have done, it was such a good experience. The moment you close the top hole, you actually didn't have to do anything.
Yeah, that would have been a dynamic thing. So once the true lumen was established, the flow would have. But there are occasions where it doesn't improve.
Yeah, of course. Then you have to deal with it separately.
Yeah. So if there is a limb-threatening ischemia, like George said, maybe if one femoral is okay, a fem-fem crossover is and then deal with the central, after that. Or when you're doing central, put a perfusion cannula into the femoral and perfuse the limb during your primary surgery as well, and then convert into your fem-fem. We have done a couple of cases.
Yeah, with limbs, I think, sort of on the other side, where I think bypasses probably are much better than, stenting is what I feel in the limbs.
Yeah, as far as the limb is concerned, you have 2-3 options. Either you can simply fenestrate, you can put a stent, or you do a fem-fem bypass.
Yeah. What is the preferred options for you?
No, it depends. See, suppose it is thrombosed because of the dissection is thrombosed. There is no way you can do a stent or this thing because you want distally embolize. There you have to do a fem-fem.
Yeah.
It's only like a situation like George said. It's only a flap that is blocking it. You can put a hole, fenestrate, and put a stent. That is fine. But if it is thrombosed, it's better to do a fem-fem.
No, fem-fem requires one femoral to be good. Now, if both are both are compromised, then you got to look out for a.
But that is very, very rare that you see both iliacs dissected.
What is more common is one is very bad, the other is slightly bad. So, like it's not normal. There's a weak femoral felt, but it's not completely gone. So then I don't know whether fem-fem is thing. I would prefer to go in and find that lumen in the aorta which has got a good pressure, if there is one, and then link that to the limb with a stent. You can always correct it later. You know, later on when you're doing the completion repair, you can just slice that flap and then stent. So you never should worry that you've stented into the false lumen.
No, if you ask me, my personal opinion is stenting in these circumstances is a never-ending story. Because where do you stent? At the origin. If you start from the origin, it's going to be a huge stent. So surgery is the best option, if you ask me. The fem, of course, fem crossover would be the best option.
What would you think of doing to the surgeons? Would you think of doing an aortofemoral in these cases? No?
Aorta is never an option.
Dissected axillofemoral is an option. We have done one case.
Why not aortofemoral? I'm just asking this because, why not aortofemoral?
So it is acutely dissected aorta.
You mean to say
it's going to tear
aorta down?
No. From like wherever you can access. I'm just asking as a from bifurcation.
Fem is a very easy operation.
Easy option.
Yeah.
Okay.
And you are not opening the abdomen. You are in the periphery. And then do the central repair. Once, central repair, most often, like we said, the lumen flow goes up. The dynamic obstruction is taken off. You may have a good flow in the other limb, which will support.
So the fem is then ligated afterwards?
No. You leave it open, close itself. That goes on,
What are the outcomes of long-term outcomes of fem crossover? I do not know how good it is.
There's 70% patency rate, 5 years. So one scenario I would like to share, sir, the iliac artery flap was there. Patient had a pulses non-palpable, but good capillary refill, the foot look pink, and there is a foot drop actually. And then ultimately we found that MRI spine was done. There was ischemia in the spine.
Paraparesis, does it really recover after the?
It improves.
You're treated with T1.
Dr. PC had a case, no? Where he said that when they recognized early, you guys put a drain in and went on to do methylprednisolone and all this stuff, and the patient recovered.
If the patient presents with.
Sir, we have a very good.
Paraparesis or paraplegia. By fixing the proximal leak. Has anyone seen a recovery?
No.
Sir, we have seen, sir. In the type A dissection, primarily presenting as a paraplegia, spinal ischemia, type A dissection.
But you will do the initial things first, right?
Things first.
Yeah, and then
I also was they may not improve, but not to 5x5 power, but with the walking stick they are able to work.
So there is a multidisciplinary paper, I think it will come in the JVS next month, is with University of Houston with Dr. Gustavo Aldrich, who actually is pioneering now not to put spinal drains in patients with TVARs and stuff. There around 150 patients were studied with paraparesis, not paraplegia, who were dealt with that have recovered to an extent of 75% after the initial treatment. And the protocol is going to come out. I think the next issue of JVS will actually talk it. But to address your question, patients, not paraplegia, but paraparesis have improved with the initial thing and then managing the cerebral perfusion pressure after.
Got one more anecdote. My own very close relative, he was a 70-year-old. He came to me with, he was brought to me saying he's developed stroke because his right limb was paralyzed. He's not able to move and he was screaming with pain in the leg. So initially I thought it was an embolism. So when I didn't even ask for an angiogram at that time. So routine examination, we asked her going to do the echo. Echo, she said, I think I'm seeing a flap. It's a type A. So we quickly did an angiogram. Found a type A has come all the way down up to the iliac. Femoral pulse was not, left was felt, right was not felt. So we moved him immediately for surgery. So did a surgery. The ascending aorta was replaced, and I did a fem bypass for him. And all pulses returned. See, he woke up and he moved his leg and he was very happy. He said, extremely good. Just as I was talking to him, suddenly he screamed, my leg is going again. He's not able to go. So he developed paralysis again. But the ascending aorta, everything else is fine. But I think when the false lumen thrombose, I think the spinal arteries went off and he developed.
This is one question yesterday I asked. I have encountered two of these patients, post your type A repair, you developed a new onset malperfusion.
Spinal malperfusion.
No, anything, visceral or limb. I had a limb post correction. Probably that entire limb was served. This was, we didn't have so much imaging. He developed and went for persistent acidosis and then myoglobinuria, went into renal shutdown. So, all these muscles were damaged. Even then, after that, we did a femferment, muscle damage was so high. So, this is an entity we should remember. When we correct the central, do a central repair, established false true lumen perfusion, there may be some vessels in the false lumen. You should always look out for new onset malperfusion.
I think, sir, we can make out from pre-op CT things.
No, after we do a TVAR,
you can, but
I
this
always do a abdominal aortogram to see what is happening over there, because you still have dissection there. And just because you did a TVAR doesn't necessarily mean all visceral organs are going to be perfused. So you may need to do more work immediately after the TVAR. I don't know if that is a requirement after doing a type A, like say FET. What do you routinely study what's happening in the abdominal aorta?
That is actually the protocol, with, the Stanford Center is like, one is on-table angio. If you have done fenestration or anything for the top, you do the angio. And also we do post-op day 1, CTA is mandatory for most of these patients. I don't know how many of us do it here, but that is one thing, as you mentioned, to do a visceral angiogram as soon as the top part is taken care of. Type A dissections, not much is done because again, it's done open and it's not being done. For that, what we do is a CT angio in 12 hours. As long as the patient gets stable, their cardioplegia is taken care of. But everybody gets a CT angio at least before they get discharged from the hospital is one of the protocols. And then you go for the 4, 3, 6 and yearly.
Wait.
No. How frequently we regularly do CT scans, George's, for type A or type B after repairs?
Type B, yeah.
At discharge. It's okay. Means like on average 2 weeks or 10 days for a type A.
I think if you have done a regular conventional angiogram at the end of the TVAR, I don't need to rush in and do a CT.
No, sir, because this is a delayed presentation. After your repair, after 3 days or 4 days, patient have a pain in the leg. You think the false lumen may get thrombose. That's what, to prevent those things.
So new onset malperfusion after surgical repair presents very quickly. So you have to
Yeah.
be just aware of it.
I think to rephrase this question is,
yeah.
Would you, irrespective of state of the patient, after you do a type A dissection, would you do a CT prior
Yes,
to
at the
discharge?
time of discharge as a baseline.
Type A and type B. No, limb perfusion or secondary perfusion, you can.
Whatever. Type A repair, one baseline CT cytogram at the time of discharge.
At the time of discharge.
No, I think type B, if you have got a good conventional angiogram showing no visceral ischemia, then that's fine. I don't do a CT before discharge.
Patients. The last question, this thing is, what are the predictors of, I've moved on from how can multidisabilities, we know they work, but what are the predictors of limb salvage success in aortic dissection patients with acute limb ischemia? What are the predictors clinically? How long can you keep let's say a 20 or a 30 French catheter, which is occluding the iliac, let us say? How long can you safely keep it in the limb? Let us say let's say doing a complex fenestrated procedure, it might take about 6 to 8 hours. What is a safe time wherein we can occlude the iliac without causing limb ischemia? I just wanted to know.
Most important is, apart from the timing, adequate anticoagulation is the most important. It doesn't matter, of course, I mean, to a point it does, but we've never had a problem as far as, even if it's a long procedure, as long as the artery, it's not the iliac, it's the femoral which is the most important. And if the femoral artery is adequate, then there is no problem most of the time.
To rephrase, what is the
say, what is the limb ischemia time? I want to ask you. Yeah. 6 hours. Okay. Achha. 6 hours.
But vascular surgery definition is 2 weeks, right? No, for your acute.
No.
But again,
What is your correct?
It's still up to 6 to 8 hours only, that is there. But everything depends on the collaterals at the level of obstruction. You have an isolated iliac artery occlusion, rest of the distal artery is normal, no time limit, the limb will survive.
So
Nothing is going to happen.
I think we're talking about two different things here. One is dissection induced limb ischemia. The other is iatrogenic, having a large sheath or delivery system occluding a femoral artery, that causing limb ischemia. Now that is a serious problem.
Yes.
Now, if you have a 6-hour procedure and you're completely blocking the flow into one lower limb, when you reperfuse, you will get a reperfusion situation. And you will have lactate washout, you'll have systemic hypotension, renal dysfunction and all that. So we are now very aware of this problem, and there are 2-3 things you can do. Number one is have a downhill sheath and have flow from the other side going down here. That is one. Second is the moment you have deployed your major graft, remove the big sheath, tie down your proglides onto a smaller sheath, so that you have flow re-established into the lower limb. So that is something which we are neglecting to do. We say we have put a 24 French device and you put a 24 French sheath and you sit with that till the end. No, that's wrong. The moment the big graft is deployed, now you're just cannulating fenestrations. Take the big sheath out, put a 10F sheath, tie the proglides down onto that sheath, and then you will get a flow into the lower limbs.
And
Nowadays, we are putting a lot of ECMOs and all, no? We are getting into that problem.
A lot of ischemia.
So we are doing that distal perfusion by a separate sheath.
Sir, if you're already thinking that the case is going to take 6 to 8 hours, like example 4 was a fenestration or something like that, we're always happy to do a open groin approach. The reason is you can have always, whenever you think that in spite of putting continuous 24 French sheath and doing the process for 6 to 8 hours and thinking about a distal to your issue, there is a clot or something like that. If it's an open groin, you can always flush it in between forward or distally. That's advantage what I feel as a vascular surgeon doing open.
But how does open groin allow you to flow, get blood flow down the limb?
No, not the blood flow. So what has happened is distal to the sheath, you always find a clots when you see.
That is a different thing. We are talking about the sheath itself occluding the iliac artery and causing.
That's where we find the clots distal to the sheath, sir. When everything is occluded there, there's no antegrowth flow during the procedure for 6 to 8 hours.
Sure.
What we do is during the procedure, we always look for at least after 2-3 hours while changing the our stent grafts and all, we have a place to just open up and flush it, antegrade and retrograde also.
So I agree that removing clot distal to the occlusion is important, but that does not allow you to have flow while the sheath is in.
We'll always have a little exchanges in between, no, sir.
But that is just a momentary flow. I don't think that
I feel comfortable if you do 6 to 8 hours.
So now we have actually moved even one further ahead. If we have a smallish external iliac artery, like say 7 or 6.5, and you're going to use a big sheath and you think you're going to take a long time, we actually now move to transcaval approach and do a femoral vein access into the infrarenal aorta, and then you're completely safe. And the transcaval is, I feel, a very underused and a safe procedure.
This is what I was just suffering to. We're talking normal human beings here, not Dr. GJ.
Yeah, coming back to limb ischemia, I think one more elephant in the room we need to address is reperfusion syndrome.
He mentioned.
Very often the limb is so badly ischemic at that time. That's not the time when we should try to revascularize such a limb. It will be a nightmare. So I think there we should.
Just a question to the panel. Dissection causing ischemia is a different issue. How many of us have ever had a problem of limb ischemia because of the procedure?
Yeah,
I've not.
To date, I have not had.
Even I'm not.
It's rare. It's rare. I don't think. Of course, we have to think about it.
Yeah.
But it should not be of that much concern, I would think.
That's what we feel more confident doing open groins.
No, I always
that's
do
how,
right.
uh,
I prefer it that way. Most of the time we've seen this happening is because you have lifted a plaque and caused a dissection. But per se, the device itself causing ischemia, I have not yet seen.
I got an experience with the perclosure where one groin is good, the other groin is gone for ischemia, where you need to open up and restitch and now. That's how when it's a long procedures, you always prepare to do open. If it's a short procedures.
No,
prefer
short,
open.
long,
Yeah.
I prefer.
That's what as I asked, I don't know, you should ask other colleagues.
That's a different issue. That is a different issue.
Yeah.
So we'll go on to the next one for want of time, 12 minutes only, because that's a very important subset, chronic aortic dissection, surgical endovascular high bridge. So what are the indications for transitioning from medical to interventional management in chronic aortic dissection? So yesterday we had already discussed that preemptive TIVA is actually coming up. Type B dissections, we did not, uncomplicated also, we did not leave them untreated based on the INSTEAD Excel trial and all that stuff. I know it's again, as I said, it's an underpowered study, but now we have got the earnest study coming up the Sunday, yesterday's IMPROVE AVD, which he says there's a lot of pragmatic things they have to consider. But for me, as of now, given the trials where I had a bit of disagreement with Shivanation, is that uncomplicated type B dissection, we know the aortic specific mortality and the all-cause mortality is definitely more for untreated on conservative management rather than treated. So what are the indications of transitioning? For me, there's no indication. If it's an uncomplicated type B dissection, an elective repair, whatever may be, should be done.
So there's like this debate is in every society, everywhere. It's especially AHA, AATS, which is American Association of Thoracic Surgery, and vascular surgeons have discussed. And we're getting more and more as we talk about it. One is everybody agrees the thing is the timing is when do you operate. Everybody agrees that doing it in subacute phase actually, helps with the remodeling. And when to intervene, obviously everybody agree if it is more than 55 millimeters or greater than 5, all that numbers we agree. Chronic dissection, if you encounter, like you say, the patient comes into you from a regular study done for something else and they've noticed a type B dissection, the patient is completely asymptomatic, probably have done 6 months ago. What do you do for it is the question. Do you go ahead and put a TVAR then if you know it was there for a year or so, somebody was, and fair enough, say he went to a secondary tier CT and managed medically. He comes to you after 2 years with a follow-up CT and you see that there's a type B dissection going on. Nothing changed from prior CT scan. What do you do then is the question.
I think it's divided here because Dr. Fujikawa was saying that you would think of optimal medical management for chronic type B dissection, irrespective of the evidence.
No, that's when it becomes aneurysmal.
Yeah, absolutely.
Once a chronic dissection has become aneurysmal, then how do you tackle it? That is the question.
No, if you have positive aortic remodeling, why do you need to intervene?
Correct. No, that's all fine. No, this is just this again as a debate I'm asking. I'll give the scenario. Uncomplicated type B dissection. Do we treat them optic medical management or do you do a preemptive TIVAR or repair?
No, Rohit, what he said, specifically said, he had a CT scan done.
Yeah.
And now it's come, there is no change.
Yeah.
Why would I touch the patient?
So that's what's saying. So I'm just talking about evidence. What the latest results are saying that the all-cause mortality and the aortic mortality is more in untreated patients.
Accept. Yeah. All that I accept. You do a follow-up CT thereafter, no? There's no harm in doing it. But if you're seeing the previous CT done after 1 year, you've repeated a CT, there is no difference. Why do you touch the patient?
No,
Is the INSTITE trial strong enough to take it as a class?
no,
or-
it's Excel, it's an underpowered study, but now it's a 5-year, I'm saying, again, this doubt is there in my head. That's the reason I'm telling.
Dr. Rohit, you are talking about acute. This is chronic. He's talking about chronic.
He's talking about chronic as well.
You are saying that preemptive. Preemptive means you have seen a dissection and uncomplicated type B. Do you want that is still going on? Okay, there are some people who argue that it should be fixed. Some people say we can go and only if it is complicated we have to fix. So that's going on. There are two schools of thoughts. But what he said was a year ago. So it's a chronic. So this discussion is chronic. So there is no preemptive there.
So chronic, let us see, now you see, we are doing a patient, again, this I'm for debate I'm asking. And so if a patient comes and incidental finds a type B dissection.
Two CTs, no change, follow up.
2 CTs, no change, no follow up.
Okay, let's see 2 CTs, there is a change. Now you want to treat. Okay, it's become aneurysmal. That is the question. Now, are there issues in that?
No.
How do you treat a chronic type B dissection, which is progressively increasing in size? Are there any issues or it's all cakewalk?
There are few papers says it's per year if it's more than 4 mm of the sac diameter.
Yeah, it is.
Yeah.
It is. Now what do you want to do?
It is aneurysm size, which you would normally treat, let's say 6 centimeters in the thoracic.
I see so many.
Abdominal is not big enough. How would you tackle the thoracic aorta?
The question here is whether you do a TVAR or do you go for an open repair? And that question is the exact question. So obviously, truth be told, we all go for TVAR to start with, but the studies say you have to consider the age of the patient and the other factors as well. And see, for the thing is, TVAR gives better 30-day mortality, we know, but the long-term reintervention rates are very high. And when it comes to open repair, the thing is that they do well long-term, based on that, even though the 30-day mortality, morbidity of those things are high. So as a debate for the panel and also for people who do both, which would you prefer in those patients is, I personally do a TVAR, and then if we have to re-intervene, comes to the patient and then go about it, because we feel like from that 30-day mortality or immediate 24-hour morbidity mortality is also very important. And to do an open aortic surgery for a type B dissection, which we think has a good landing zone that we can cover, I think endo is a better option. At least I may be wrong, from the data shows otherwise, but
I think the determining factor also is right at the beginning, what is the size of true lumen? Because there is this argument that the septum will not yield once it is chronic. So I think that also needs to be considered when you are contemplating the TVAR versus open. I think if somebody has extensive open experience for chronic.
So we will have a talk on this by Fujikawa about surgery for.
Okay.
So the surgical part will be sorted out. Anyone wants to comment on TVAR and the problems that we face while doing TVAR for chronic aortic dissection?
Yeah, I'd like to describe 2 anecdotal experiences which I think captures the situation. So I had this gentleman who's had a type A actually repair done long ago, Star Edwards valve, and now he's got this totally degenerated arch and descending. And the arch is giant, it's like 7 centimeters. And in the descending, the true is absolutely thinned out, and the false is big. So early in my experience, I did a total arch repair, and like before I mentioned, I did a true lumen endograft all the way to the celiac artery. Great result, all fine. And we kept following up this patient. Now this patient had a normal heart when I did this procedure. He's got a Star Edwards aortic valve, by the way, but that was functioning normally. Now, over the next 1 year, he progressively went into heart failure. And he died of heart failure. And there was nothing wrong with my graft. But now I realize there was something wrong with my graft. That is, I had shut off the huge false lumen. And in the descending aorta, there was this small true lumen, which was acting as an afterload.
Yeah.
And it created
It's like a long coarctation.
Exactly. So that was case number 1. So I got worried about this, and I got one more case like this, and I did the same thing, but this time I did a balloon dilatation of the endograft in the true lumen with the idea of not having any gradient there. And I did it, and soon after the procedure, patient started saying chest pain, chest pain. And then he just collapsed in the ward and he had a hemothorax. So what happened was, while I did this balloon dilatation of the true lumen, the falls, which was still filling from below, had ruptured and caused a hemothorax. So when you dilate the true lumen, even though you're in an endograft, you cannot control what's happening outside it. And the falls can still rupture. And
so that was like a D sign and
no, not
sort of.
behind. This ruptured higher.
Higher up.
Yeah, and the falls was filling from below. So what I should have done is I should have done a candy plug, made sure the falls thrombosed, and then only done this aggressive dilatation.
So the falls dilated and ruptured because of increased flow from below.
No, the falls ruptured because I did a aggressive balloon dilatation of the endograft in the true lumen. So that the true and the falls, that internal flap that separates the two, when you tear it, the tear may extend outwards. You cannot control what happens there. So the falls actually started bleeding, and the falls was being pressurized from below. So maybe I should have done a candy plug, waited for the falls to fully thrombose, and then done the dilatation of the true lumen, because there's a pressure gradient there. The true, which is a chronic true, it's like years.
Are you saying that when you did the balloon dilatation, you actually perforated the true and false and communicated with the false? Because it's very, very unlikely that retrograde filling of the false lumen can cause.
No, the retrograde filling of the falls is not what caused the rupture. The rupture is because my aggressive balloon dilatation. What I'm saying is you have a true and a false with a flap in between. You put an endograft in the true and you dilate the true. Now the flap will tear. And when the flap tears, it can also involve the wall of the false lumen. It's thinned out the false lumen. So there can be a new, like a rupture. And how is this getting blood? It's getting blood.
So we are running about, thank you. We are running about 5 minutes late. And,
Yeah, time is up actually.
Oh, wow.
You have something. No, you have something pressing to. We can give you 5 minutes, not a problem.
I said we're running 5 minutes, we'll finish.
The other thing is after TVAR, I think the incidence of hypertension is very high because the aorta becomes stiff. So there is an incidence of hypertension very high. That also acts on other.
So I wanted to ask this question because who's who of aortic surgery are all present here, and this is a debate which is going on in the Western world as well. This is a very yes or no question in terms of, do we agree that aortic work and complex work and dissection work that we all talked about today, has it to be done, like should we have like a protocol where the surgeon or the institution which is offering these protocols should have a minimum number of cases that they have done to be qualified to offer these services to the patients? It's not controversial, but we do agree.
No, Karthik, the thought is good.
Yeah.
Wherever higher volumes are done, I mean, there have been enough studies in different disease processes, the results are better. Frankly, for this group or any other group, it's impossible to enforce that.
Yeah.
So ultimately, what happens is wherever good work is being done, I think sooner or later patients start percolating to that place.
Okay.
That is what will make the difference. We don't have any legal structure in place as of now that we enforce this.
Sure.
So thank you so much. Good discussion.
Thank you all.
Just like our all our guidelines, you can write guidelines, Indian guidelines, big society. Who the hell follows it? And how do you enforce that? Nothing.
Thank you. So a very interesting talk now by Dr. Takuya Fujikawa on something that we've been discussing, surgery for chronic aortic dissection.
Good afternoon. So we move on to a surgeon, and it will be enlightening to see. I think still some of the surgeons are here. We should seriously look at open repair for chronic aortic dissections. I know unlike the ascending aorta, the descending aorta has been having higher mortality rates world over, of course, but Coselli reported a mortality rate of about 5 to 7% now, and this is what we should strive to achieve, so that we can have more patients on the descending thoracic. And Professor Fujikawa was in our center last year, so for the Aortic workshop. And one thing I can tell, he enjoys Indian spices. And I told him, you're in Hyderabad, Andhra is known for its spices. And hopefully, PC, give him a good spicy food today.
Not too spicy.
Oh, yeah, I know. That's what I said. Over to Fujikawa for his talk. Thank you.
Okay, thank you very much. Thank you again for inviting me to India and give me this kind of good opportunity to present my modest experience. So today my topic is open surgery for chronic dissection. So 5 reasons I choose open. First, definitive procedure. Second, less morphological limitation. Third, low reintervention rate. Fourth, long-term durability. And fifth, only surgeon can choose open. So there's a lot of innovative devices. I know a lot of innovative devices. If you look at this exhibition area, you can see a lot of new devices. However, still preparation of open is mandatory because TIVA cannot solve all of the problem. However, a lot of cardiac surgeons can perform easily total arch replacement or TARFET, but as for the descending thoracoabdominal, it's a little bit different because it requires completely different approach and different preparation. And the number of surgeons who can manage well is limited. And furthermore, this kind of complicated operation requires collaboration with nurses, anesthetists, and perfusionists. So we need to make a pragmatic approach. So my personal experience is in Japan, I experienced more than 300 cases of open descending and trained and I supervised junior since 2011 to 2016. Then I moved to Hong Kong since 2017. At that time in Hong Kong, there's not so many open descending thoracoabdominal. So what I did is this kind of approach. So always I draw this kind of drawing before the operation and share with nurses, all of OT staffers, and discuss in advance. Then normally I organize pre-op briefing. And even after successful operation, we organize post-op debriefing as well. So this kind of cycle is make them confident to the procedure. So now open descending and thoracoabdominal is one of the routine procedure in Prince of Wales Hospital in Hong Kong. So after I joined, the number of left thoracotomy surgery had been increased. And the distribution is like this. Open descending is 48, and the thoracoabdominal is 15 cases, and left thoracotomy total arch is 4 cases. So let me focus on these 63 cases of open descending thoracoabdominal. If you look at this kind of pathology, most of them are chronic dissections. So 46% is chronic type B and 28.5% is chronic type A. Chronic type A means after hemiarch or total arch replacement for the type A dissection. So that means most of them are residual dissection. That means chronic dissection. And previous elephant trunk is almost 19 cases, and the previous TIVA was 7 cases. And the non-elective case is actually non-elective case ratio is very high. So nearly 40% is count with rupture or impending rupture. And actually, of all cases, I removed 6 stent grafts. So recently, the operation for this kind of descending thoracoabdominal is getting more complicated. But if we know keys of strategy of open descending thoracoabdominal, it makes us more confident to tackle this issue. So these three issues, distal arch management, esophageal dissection, and visceral exposure. So as for distal arch management, there are two options. First, TAFET and or open proximal with circulatory arrest. That means left thoracotomy surgery. But even you perform TAFET, it may require second stage intervention. But if you implant TAFET first, actually the operation itself is not so difficult. So this 10 series of previous FET group is a 6 is a Troflex and 4 is Evita. Each stent has each feature of stent structure. So if we know the structure of the distal edge of frozen elephant trunk, it is not so difficult to anastomose. Actually, all of artificial material. So if you choose a meticulous anastomosis, you can avoid unnecessary bleeding. So I will show you one case of post-TAFET. This is Evita and dilated descending aorta. So we proceeded open surgery. So left thoracotomy via the fifth intercostal space and expose descending aorta. Then I use epi-aortic ultrasound. This epi-aortic ultrasound make it easy to identify where is the distal edge of frozen elephant trunk. Then just we mark it and we don't need to dissect too much to the proximal, just identify the enough clamp area. Then clamp on the frozen elephant trunk, because after TAFET, there should be no type 1A injury. So and this is the distal sign of Evita. Then you can find Evita. Normally, I don't find any unnecessary thrombosis in each frozen elephant trunk devices. Evita has some this kind of flip in the distal, so I'm trimming this edge and anastomose using almost similar size of graft and taking only 2 mm bite and very meticulously take stitches and try not to make any discrepancy and try not to make any dog ear. It is very difficult to stop bleeding. But if you can fit the diameter of frozen elephant trunk and vascular graft, after the clamp, no need to worry about the bleeding. So this is a post-op CT scan. So this is a basic strategy for the second stage intervention after TAFET. So how is the open proximal with circulatory arrest? Some patients cannot clamp proximal. This is one case of distal arch aneurysm with chronic dissection. This patient was implanted jumbo disc previously, and the jumbo disc stent graft is fractured. So again, we expose a whole descending aorta and go on bypass from left femoral artery and femoral vein, and cool down to 25 Celsius degree and clamp mid of descending aorta. Then open the aneurysm. Subsequently, we can remove this kind of custard cream, and it looks very tasty. Just kidding, sorry. And then open up aneurysm carefully. And you can find a fractured stent graft. Once you remove part of a stent graft, you can identify easily the ostium of neck vessel. So that means we can give antegrade cerebral perfusion from left side. Cardiopressure also can be given through the ascending aortic graft using occlusion balloon. Then once aortic arch is transected, it's nothing special to anastomose for the experienced aortic surgeon. So actually same procedure with usual total arch or usual hemi arch. So this is some kind of distal hemiarch or distal partial arch replacement. The point is need to be careful, try not to drop any debris to the neck vessels. So this is a completion. So this is, if you have this kind of option of left thoracotomy, circular left, it may be broaden our option for the arch management. So when it comes to esophageal dissection and visceral vessel exposure, this is a basic knowledge about abdominal aortic replacement. So I show my basic operation for the TAA repair, and patient positioning is almost similar. Then open the chest. After exposing left pleural space, then extend the incision to the abdomen. Normally, I open the peritoneal space. And inside the diaphragm, from the 5 cm distance, 5 cm distance from the chest wall, then enter just in front of psoas muscle fascia. So this is the key of this approach is don't injure psoas muscle fascia. If fascia is destroyed, the muscle, exposed muscle, easy to breathe. So drying is very important part in the abdominal aortic replacement. Then if you identify left renal artery origin, almost all preparation is done for the visceral vessels. Then next part is dissecting esophagus from distal descending. Because one of the risks of this kind of operation is esophageal injury. But once you enter the proper layer, I normally ask the anesthetist insert TEE to the stomach. So you can feel the TEE using your finger. Then I push in this kind of gauze between descending and esophagus. So aorta is still beating. So this part is spontaneously dissected. And this is my basic method of intercostal artery reimplantation. So make this kind of button, island button, and using interrupted suture. So to avoid unnecessary stealing, I insert 3 French Fogarty catheter to the intercostal artery. Then visceral reconstruction is almost similar is usual vascular surgery. So all vascular surgery can perform this kind of anastomosis easily. So this is a completion of Crawford type 2 operation. So based on these keys of strategy, distal arch management, esophageal dissection, and visceral vessel exposure, all other procedure is from this basic knowledge, addition or subtraction. So if aneurysm is more extended, you can choose easily. This is one of the extensive procedure, more than distal arch replacement. So this patient was inserted T-bar and after a hemiarch replacement, and distal arch has been ruptured. And the visceral part is bare stent. So I performed left thoracotomy total arch replacement. Same with previous jumbo disc case, and established cardiopulmonary bypass, and LSPV, LV vent and cooling. Then open the aneurysm carefully. Actually, for this kind of operation, key is 3 knowledge and exposure. Once it exposed well, suturing itself is nothing difficult, not too difficult at all. Then remove the stent graft, and this time identified ascending graft. Of course, this is the total arch replacement from left side, so we can give ACP through the neck vessels. And for branch graft was anastomosis. This case, left subclavian artery was already occluded, so I didn't reimplant left subclavian artery. So then neck vessel is reimplanted one by one. So after finishing the distal anastomosis, almost all procedures done like this. So another case is candy plug removal. This is one example of a subtraction case. So this is a pre-op CT, and this patient was implanted TIVA and candy plug, but still some end leak and causing distal arch enlargement. So again, we went on bypass and identified the distal edge of stent and clamped the distal of left renal artery. Then opened the aneurysm. But this patient, other intercostal artery has been already occluded. So I want to preserve some pairs of intercostal artery. So this time I didn't dissect too much for the visceral vessel and removed candy plug. Afterward, it was obviously this patient doesn't have any type 1A end leak, so I anastomosed, including a stent graft and aortic adventitia. Then for the distal anastomosis, I use a very long oblique trimming because just next to the celiac artery, there is only one patent intercostal artery. This is almost a lumbar artery, so I want to preserve that pair. So this is basic. Actually, in this case, I just first continuous suture and applied whole circumference reinforcement double pledged suture. Then we can achieve. Actually, you can see this is pump sucker, so this is full heparinite, but no bleeding at all. So post-op CT scan is like this. Of course, detailed pre-op planning is also mandatory. So as I said, especially in the complicated aortic case, I normally draw this kind of drawing and share with my colleagues in advance. So the operative mortality previously 75%, and after I joined, it reduced to 9.5%. Still not 0%, but when it comes to elective case, the mortality is 3.2%. So I think it's acceptable result for the open surgery. Then still spinal cord injury is an issue in all cases, and additional operation was required in 5 cases. Some is a development of distal arch aneurysm, or some patient got infection. So this is or some cases required TIVA. Then 5-year survival is still 55.1%. So actually recent open surgery for descending and thoracoabdominal is much increased after I joined. So maybe stent company want to kill me because the number of TIVA is much reduced. I hope I will not be killed. And anyway, as I said, there's a lot of innovative devices, and maybe some innovative people open surgery may be an out of date dinosaur. And I know a lot of young trainee is jumping onto the open endovascular surgery. And the previous ice age, all dinosaur had died out. And is it the ice age or it truly ice age for the open surgery? Actually, today in Hong Kong, the number of operations done by me is gradually decreasing because I share my experience and my colleagues can perform this kind of operation. And sometimes Actually, this propose extent 3 or descending with circulatory arrest was done without me, then I'm not in Hong Kong. So I'm very happy with this kind of achievement. So now new dinosaurs are still emerging. And so materials for open surgery have also evolved. For example, new frozen elephant trunk device, and sometimes we use new stitches and sometimes new grooves. So we are evolving dinosaurs. So we never die out. Thank you for your attention.
That was a very excellent and inspiring talk, I should say. So some doubts like if often the chronic type B dissection, the dissection enters entire aorta, even though aneurysm is there in the proximal DTA, the lower DTA and abdominal aorta will be little ectatic, maybe around 3.5 to 4 centimeter. So how much you will replace? Like what level, up to what level you'll be replacing the open surgery?
Normally, it's one of the topics we discussed in the previous session. So when we intervene to the chronic dissection. So chronic dissection, I intervened the chronic dissection 55 millimeter. That means less than 55. I mean, less than 40 is actually normal, same with normal aorta. So if it's just only 40 millimeter, we can leave the distal part of abdominal face. So I normally replace descending, and if it's just only 40, even 45 is accepted. Try not to extend my procedure. I try to minimize my operation.
And how many patients you have seen that remaining 45 and remaining aorta keep expanding later on because we penetrate at the distal end?
In Hong Kong, as long as I experienced 4 to 5 cases in open descending required Profold 3, type 3 repair.
How do you question is like you have done a distal penetration into a dilated aorta.
For the chronic dissection, all cases I perform distal penetration.
So how many of these patients are having later on dilatation of the remaining aorta?
So that means 4 to 5 cases.
Okay.
No, how do you tackle that distal intimate flap?
Just cut with scissors.
Longitudinal.
Yes, yes. I cannot use any sophisticated way, just cut, remove.
I think that holds good even when we deal with arch and in chronic dissections to slit the distal septum down.
Yes.
When we do a full arch as well.
Yeah.
That helps to balance the pressures of the
Normally, you mean when I tackle to that?
penetration distally beyond your graft. Yeah.
So you mean when I
No, I got it. You slit it. So
Ah.
I was just mentioning, even in chronic, not in the thoracoabdomen, when we do a chronic dissection involving the distal ascending proximal distal arch as well, it is good to slit the descending aorta a little bit.
Yes. So even when I perform the proximal open proximal procedure, if there is residual dissection in the arch, I perform penetration.
Correct.
towards
Exactly.
proximal.
That's a very important point. Yeah.
And what was case you showed are mostly proximally already addressed with the PET or something. If there is a chronic type B aortic dissection with aneurysm, so where will be the proximal, where you will do the anastomosis at beyond the subclavian? Because the dissection starts just at the level of subclavian. So we'll go in between carotid and subclavian, or how is it routine?
So you mean from left side?
Through left side, yeah.
It depends on the size of and shape of aneurysm. And sometimes I need to reimplant the subclavian artery. So that means zone 2 anastomosis from distal side.
In your series, have you encountered any cases of stent graft infections for which you had to go in?
In Hong Kong, I haven't experienced stent infection.
But in Japan, you have?
In Japan, quite a lot.
What will be your option?
One case is not obvious infection, but esophageal perforation. So that case
Graft eroded into the esophagus.
Yes, so remove the stent and remove all aortic wall, and we collaborate with esophageal surgery. So this is the left thoracotomy open descending. So after after remove stent graft and esophageal wall, we replace the descending first. Then esophageal surgeon, this was a very skilled esophageal surgeon, so extend the operation, incision to the abdomen and make the stomach duct and pull up to the, and resect the damaged esophagus and anastomosis here. To reconstruct this esophagus using stomach duct. Then there is a omental flap is here. So we could wrap the graft. Then patient, at least it was, the operation was probably done in 2013 or something. And at least then I left from Japan. Patient was still doing well. So this is one of the options. But actually, infectious disease is first of all, we need to remove or stent. So FET makes it very difficult, I think.
You mean you have to move the stomach up just for the sake of omentopexy?
That patient is esophageal perforation, so esophagus needs to be resected. Yeah. Sorry, my explanation poor.
Then you always use a separate graft for the viscerals, or you don't do that?
I
direct
use
anastomosis on the.
In Hong Kong, Cossery graft is not available, so just use normal 4-branch graft.
No, you don't do that Crawford technique of suturing the, like a button technique, parallel patch and suturing? Patch.
For the all visceral vessels, normally I don't use. So the candy plug case is a very special case because I make separate each ostium. It was very close to the intercostal artery I wanted to preserve. So that's why I use that kind of oblique suturing and island technique. But normally I don't use island technique, just separately reconstruct. It's less chance of future aneurysmal formation.
And you do that before clamping? The side branches in the graft, you create first before you open the aneurysm?
You need to, sorry.
See the side branches that you are using for anastomosis to the visible arteries.
Side branches.
He's using a 4-branched graft only.
Yes,
Only one
it's a infusion limb.
Already in place.
Prefabricated or
Prefabricated.
The Cossery graft is
similar.
It's surprising Hong Kong doesn't have a Cossery graft.
I haven't used Cossery graft in Hong Kong, so normally I use just normal 4-branch graft.
Sometimes you have a stent graft eroding the esophagus and giving rise to mediastinitis. You know, the esophageal tissue is quite weak.
Yeah.
What is your approach to such a case?
Fortunately, in Hong Kong, I haven't experienced this kind of eroding stent graft. So probably if you find this kind of stent complication, earlier intervention before erosion from the aortic wall is better. Because not only this kind of stent graft complication, but also all aneurysm. Of course, a lot of surgeons want to avoid operation, but if aneurysm is getting bigger and bigger, it causes some inflammation on the surface of aortic wall. So it may easy to cause lung adhesion and esophageal adhesion. So earlier intervention, but not too early, is a better option.
Invariably, those cases you have to explant and debride the tissues. We use either rifampicin coated graft or bovine pericardial tube graft to replace the aorta. Bring the omentum in between the aorta and esophagus, and patient will be on feeding digestion. It's a long process.
Because the stent is inside, the aortic valve is not eroded.
Invariably, they will have an infection.
Yeah, they will have an infection.
It is infected only.
Okay.
It is aortoesophageal fistula.
Yes, of
So the
course.
aortic wall is there.
That's the problem with the what replacement we use. I had 2 patients.
Replace the stent.
Replace with
Stent graft.
bovine pericardial.
One case I used to diagnose with omentopexy. Luckily, There is no, it's always infect. So, and I think the other thing with the advantage of this dissections, the chronic dissection is when you had huge aneurysms with a lot of thrombus, had one patient compressing the left bronchus and the PA, pulmonary artery. But if you do a stent graft, that compression element is not taken off. So with open surgery, you're able to evacuate all these clots. I think, but hoarseness didn't return back, but I think the compression was became less. That's one advantage of this. So dinosaurs are emerging, and I think it's complementary. I think there are situations where the only thing is we have to, as surgeons, increase our expertise, like the results you showed. Very impressive. 7% mortality for thoracoabdominal. I think the volume of work in India we do thoracoabdominal, very few surgeons do significant volumes. I think we have to, as a community, improve. We should make more dinosaurs come up. Thank you very much. And with this, we close this wonderful session. And
So that finishes the presentations. My colleagues have prepared a small sort of consensus. We won't really be voting on this immediately, maybe show of hands. And if you think there are other things that we need to decide on, we will add it in this and send it out as a Google form to all the participants. And probably after we get the results of the survey, we can try and make some sort of a document as to what we have thought of. So these are some of the questions which are here. Which imaging modalities would be mandatory for diagnosing and classifying aortic dissection? CT, MR, 3D, or aortography? I think the answers are quite obvious for some. To what extent do you agree that multidisciplinary care teams are essential for optimizing aortic dissection outcomes? Which factors should be prioritized in risk stratification for aortic dissection treatment? Shashank, if there are any suggestions, just make a note. What is the maximum acceptable time window for initiating surgical intervention in type A dissection? Assuming the patient has come to the hospital and is stable, do you want to operate immediately or do you want to sort of wait for some time? We do face logistic problems when family is not there or they're arranging for finances, some clearances. So can we wait? When should FET be the preferred approach for type A aortic dissection? And how frequently should patients undergo imaging surveillance post-Bentall procedure to monitor for residual dissection or complications? Which criteria best define complicated TBAT requiring urgent intervention? I think this has been discussed quite extensively. For uncomplicated TBAT, when should early TVAR be considered over medical management? I think the only evidence available right now is the INSTEAD trial, and of course, a randomized control trial is underway that was presented yesterday. What is the optimal pharmacological regimen for management of TBAT? I think this Shireen also did speak in a presentation about using beta blockers and ARBs. What are the primary indications for intervening in intramural hematoma? When should intervention be prioritized for PAU? There are times when patient comes in and we waited, either the pain doesn't subside or patient comes back with increasing pain. So when do you sort of say, okay, patient can be conservative, and when would you like to operate immediately? Then non-A, non-B dissections, how do you manage them? Treat them as type A or type B? What is the preferred initial approach for managing visceral ischemia and acute aortic dissection? Again, I think discussed very extensively yesterday and today. For chronic aortic dissection, when should intervention be considered over medical management? And this is like, it's open, whether it's surgical or endovascular or hybrid, but when should you intervene? What is the recommended imaging interval for long-term surveillance of treated or medically managed aortic dissection? To what extent do you agree that endobental could become a standard repair for type A dissection in the next 5 years? And not only type A dissection, even for some other chronic diseases. How should genetic testing be integrated into routine aortic dissection management? So should we make it mandatory for all patients, or should we have an age criteria cutoff, or should we look at some of the clinical features and then take a call? What is the most critical barrier to implementing advanced techniques in low resource settings? And what is the most urgent research priority for improving aortic dissection outcomes? Are there any additional recommendations for 2025 global consensus guidelines? What we are sort of going to try and prepare some document that we will circulate amongst our group. And what are your thoughts about the National Aortic Registry? And I think knowledge is power. Once we have a registry, we have more organized data. Right now, we talk about I saw this and he saw this. And while some of us have very good record keeping, some of us may not have enough record keeping, enough follow-up. And we really don't know what happens to these patients. So if we are organized and have documentation in a standard format, one, we don't miss data. Second, it gets documented in one place. And third, it will also encourage us to follow up our patients more diligently and see how they fare in the long run, whether with interventions or without interventions. And probably it also helps the patients, because if we are following them up, we will identify those patients who require intervention during follow-up before they come to us with an emergency. So if most of you will agree on this, we will work on creating a format for the registry, take all your inputs about the data set, and then put it into place so that data can be put in online. And as I mentioned earlier, people are always concerned about data privacy and patient confidentiality. I think that is a very, very standard thing for all registries which are in place, and those will be ensured. What changes or additions do you suggest to improve current training programs in aortic disease management? And I think this will apply to all these specialties or all the specialists who are sitting here across the board. And one of the things I think we need to do is probably come together as teams in our hospitals and try and integrate aortic work amongst the team so that the trainees in different departments also get exposed to various options that are available for managing these patients. Otherwise, for an interventionist trained only in interventions, that seems to be the only option available. So we need to sort of broaden our horizon as to what options will be available for our patients so that we do the best for the patient. So that sort of brings us to the end of the session. This will be circulated. If you have any suggestions, you can voice them now. If anything else should be added to this, we will make a note of it, or you can send them to me personally and we will integrate them in the document before we circulate it. So we'll wait for a couple of days before to get some suggestions and then circulate the document. And it's open house. Any comments, suggestions, whether academic or organizational or plans for future, please feel free before we go for lunch.
I think this plan of a registry is absolutely required. Now, concept of registry is nothing new to us. All our societies have had registries and all have failed. You know, there has been nothing of significance that we ever achieved as an Indian database. And so what I found over the last few years is that there is very little cooperation between societies. Okay, the vascular society, the radiological, the cardiological, they are bitter enemies. They wouldn't even talk to each other. I mean, that's the practical thing. So I feel there is a more hope if we go individual or institution based. Okay, so if individuals get together, or institutions get together, there is a better chance that we'll get a more meaningful registry. And we don't need to have the whole country involved. Of course, it should be open to the whole country, but if a few centers could bring in good data, that itself will be a great thing. We don't need to have the entire, every single case done in the country, but if some good data could be got from a few centers, that itself will create a very, very interesting database, because we don't know what's going on in India. It's we simply have. So there are two things we could add to this. One is genetic testing. So we could routinely genetically test our patients, and we should find the resources for it. But it's 19,000 rupees, which is, I think, not too much. And it gives so much data that you can't believe it. That the authenticity of the data is much more if you have a genetic test. Second is follow-up. Now, we're all busy clinicians. We don't have time to follow up. So what I would suggest is we authorize whoever running the database to call these patients and ask, are you alive? What are you doing? So when you hand in data to the database, include patient's consent to be called later and asked how he's doing by somebody. You could have a person employed just to call these patients.
We can have an administrator who can do that.
Yeah. So I don't think if you leave it to each hospital to do, it will never get done. So you need to have a central person who's been authorized to just call the patient. How are you doing? Have you done a CT? Can you share it with us? That's enough. These are my suggestions, of course. You can have different ideas.
No, I think those are very valid, because as societies, it is very difficult for us to come together. I mean, we were working together, some of the societies, and then the gap has become quite wide and people are really still moving apart. I mean, the process of even slowing down and coming together is not there. But then, of course, there are many of us in different societies who think that working together with different specialists makes a lot more sense than working individually. And that is one of the reasons why all of us are here. And so we create a registry which doesn't belong to a society. It belongs to us.
No, I absolutely agree. If you go society-wise, it's not going to work. I can tell you right now. I think high volume centers should get together and have this. It's a very valid point that George mentioned, that the inherent problem with our country is once the patient is all right, he forgets you. So whatever you do, you take it in writing that good follow-up doesn't happen. It is your prerogative to go and contact him. And if there is a central office or whatever, who can do it, that would be the best way to do.
So that can be organized. So you see, most patients are spending a few lakhs at least for the treatment. So if we are testing only the patient, adding 15, 20,000 is not a big deal. I mean, we can actually sort of try and include it within the treatment plan that a sample has to be taken. The problem arises when the family needs to be tested. But families definitely would be a little more compliant with the testing if they find that the index case has a genetic problem. That is the time when we would want to test close family members. And I think they would be more willing to listen that the testing is required.
But can we have because there are a lot of cities that don't have it. So we need to know which are the centers which do this genetic test.
So what we can do, we can actually talk to a couple of companies. What Rohit suggested, one of the companies, Map My Genome, which does good testing and they even do counseling. We can negotiate with them and probably even bring down the pricing. And the sampling can be like we had a patient I had done a case with Dr. Saha, and we wanted genetic testing for that patient. He was not even in Kolkata, but the company organized for somebody to go and take a blood sample from his village and do it. So the companies are willing to do it. We just need to tell them.
So if we can have these contacts of these.
Yeah,
companies,
absolutely.
Even on this, our WhatsApp group, if you can.
Sure.
do that.
We can do that.
So it will be easier for us to get it done.
So
Convincing the
always
patient is not an issue.
Sure. We'll share the details.
Your negotiation power will improve if more people start sending this. So
Absolutely.
the cardiac surgeons WhatsApp group, vascular surgeons WhatsApp group, IR WhatsApp group, if we spread this contact, and those guys may get surprisingly high number. And then our power will be better.
Sure. Any other suggestions, comments? Yeah, Pradeep.
I think there is definitely a like-minded across all specialities we can find here. And we always have difficult cases, when we are faced with not necessarily, acute dissection where decision has to be made then and there. Maybe see whether you or other people can see with the help of industry people how we can share these images and actually gain that experience. Of course, registry is the ultimate way to go forward. But in the meantime, like how you get cases from Subbu or somebody, is there a platform that can be created with the available IT systems that are there now to share and learn from it? Because obviously at the end of the day, that will improve the outcomes and some things can be achieved. Whether it is practically feasible or not, just a thought I had. Because these are all complex things, because we regularly face this. Yeah.
So what we've been doing so far, when we have a very complex endo case, we talk to George. When I have a complex open surgical case, I speak to Shiva, I speak to Ajay, and we take their inputs. So that is what we've been doing so far. And it's been working out. But complex cases that people have done that we learn from, they can perhaps become part of this meeting also. This has been a good discussion format, but a little monotonous also. And sometimes how to carry forward the discussion was becoming a bit of a challenge. That is what I noticed. So maybe we create clinical case scenarios, have some interesting cases. We would still like to stick to the format where we don't have sessions with just lectures going on. Ultimately, the aim is to have a lot of discussion, but create situations around which discussion can take place and people learn from that. And if most of you are okay with this format of a meeting, we can actually improve on the format with clinical case scenarios, some cases which you can send in and present when you come here. And we can make it go beyond dissection. So dissection can be part of it, maybe other complex aortic pathologies can be made part of it. And we could do that.
I think live in box is a fantastic idea to liven these meetings, and the learning can be huge, number one. Number two, this cross consultation for challenging cases. We have been routinely we formed a WhatsApp group of all the seniors across India. I'm surprised at how many cases are getting poured in from juniors who are especially not staying in metros. And in a day's time, how much opinions are pouring in from top people. So that has really changed the outcomes over last 4 years. But I think you could think of something like that. So Aorta group, add people from all the 4 streams. And how do we put in the images, or whether some industry guy could partner with us where quickly images could be spread to them. And I think we'll get very valuable input, especially for people who are in the middle strata. They will get very valuable input. It's a very good idea.
So one thing is the group that we have created, it consists of all specialists, and you can suggest anybody else needs to be added. But one good idea might be to go on to Telegram rather than remain on WhatsApp. Because it's much easier to put larger files on Telegram. It's also a more secure platform. But then if you're not using Telegram, you will all have to start using it.
That can be done. That's not a problem. As long as the message reaches
Yeah.
and messages come back.
Because it's immediately visible on your phone. All other sort of emailing groups and others, it takes time. I don't know when people would refer to that, but Telegram is just like available like WhatsApp. But as I said, much bigger files can be sent on that. So we can transfer the entire group to Telegram. So there is no confusion also. And you want to add anybody else, you're happy to do that. And some of you can be administrators and add people on your own. You don't have to ask anyone. Mr. Seshadri, lunch is ready. So any final comments or suggestions? Otherwise, we can.
Very neatly done job.
Thank you, sir.
Very, very disciplined.
No, I have a very good team. I'm the
Gotcha.
face, but actually they've been doing everything in the background. And I've been telling them they should come forward, but they just refuse to do it. So thank you, everyone, and join us for lunch and safe travels. And we will hopefully meet maybe after a year or so, once again. But of course, in different fora, we will keep meeting. Okay, one group photo. Everybody, please come up.